Okay, first thing is basically the embryology again. Okay, and for this part, you need to understand what structures in the GI system derive from which embryological part. Okay, so we have three structures initially in the embryo: the foregut, the midgut, and the hindgut. Okay, now this foregut, midgut, and hindgut, they will form all the structures of your GI tract. Okay, for the foregut, it will form the structures which will come between the esophagus and the duodenum. Okay, so distal 1/3 part of the duodenum. Okay, then comes your stomach, pancreas, gallbladder, liver. Okay, then the antrum of the stomach and the duodenum part. Okay, the proximal duodenum. Okay, this is formed because of the foregut. Okay, second structure is the midgut. Okay, after duodenum, the distal part of the duodenum, or I can say the lower 1/3 of the duodenum, okay, to the proximal 2/3 of the transverse colon, okay, and that includes such structures which are the distal duodenum, okay, the jejunum, the ileum, okay, then cecum, then ascending colon, and then the transverse colon, the 2/3 part of the transverse colon, okay, and that even includes the hepatic flexure, okay. It is all formed by the midgut. Okay, then comes the hindgut from the distal 2/3 part of the transverse colon and up to the rectum. Okay, just above the pectinate line or the anal canal, just above the pectinate line. It is formed by the hindgut. Okay, so three structures. Just remember, from esophagus to duodenum, every structure that you encounter in the GI tract, okay, they all are derived by the foregut. From distal duodenum to the transverse 2/3 colon, okay, all the structures are formed by the midgut. Then comes the hindgut, which forms the structures from the distal 1/3 of the colon and to the anal canal above the pectinate line. Now you need to understand, these three embryological origins, the foregut, midgut, and hindgut, they're supplied by certain nerves, okay, certain parasympathetic supply, certain sympathetic supply, and certain blood supply, okay. And so all of these structures which are listed here, they all are derived by, uh, you know, sorry, all of these structures which are formed by these origins, okay, they all are supplied by the same nerve and the blood vessels, right? So for the foregut, okay, uh, this foregut is supplied by the celiac artery, and so that all the structures between the duodenum and the esophagus, they all are supplied by the celiac artery, okay. For the sympathetic flexes, you have uh, the splanchnic nerves, okay, the thoracic splanchnic nerves, and these are from T5 to T9. If you guys remember the thoracolumbar division, okay, this thoracolumbar is your sympathetic system, right? So for the thoracic splanchnic nerves, these are the sympathetic nerves for the GI tract, okay, and the T5 to T9 part, they all supplies the foregut, okay, and for the parasympathetic, you have the vagus nerve, which is a cranial nerve 10, a part of your parasympathetic nerve, okay. And whenever you have any problem with the foregut, any kind of inflammation in any part of the foregut, the pain will be referred to the epigastrium. Very important. The pain will be referred to the epigastrium, okay. Then comes the midgut. For the midgut, uh, this part is supplied by the superior mesenteric artery. Very important, okay. And the nerves that supplies here, these includes for the sympathetic ones, these are the splanchnic nerves, again the thoracic splanchnic nerves from T9 to T12, okay, T9 to T12. For the parasympathetic ones, it is your vagus nerve, okay. And so all the structures between the distal duodenum up to the proximal 2/3 of the colon, they are all supplied by the superior mesenteric artery, vagus nerve, and the thoracic splanchnic nerve T9 to T12, okay. And whenever you have a pain anywhere in this, you know, in between the duodenum and this transverse colon, any kind of inflammation or any kind of infection, the pain of that problem will be referred to the umbilicus because of a T10, the presence of T10 nerve roots. Okay, all of the pain will be referred to the umbilicus. It is very important to note. Then comes the Then comes the hindgut. Okay, and the hindgut is supplied by the inferior mesenteric artery. Okay, and the nerves which supplies here, they include splanchnic nerves, which are the parasympathetic. Now, note the fact that the splanchnic nerves here, okay, they are the sympathetic ones, but they are the thoracic splanchnic. Okay, for the pelvic splanchnic ones, the S1, S2, and the S3, they are the parasympathetic. Okay, if you guys remember the craniosacral division of your body, the cranial and the sacral part, these are the parasympathetic ones, right? For the sympathetic ones, the thoracic part is over at this T12, and now the lumbar part will be started. The thoracolumbar division. So now the lumbar part will be started, and this is your sympathetic supply, okay, of the hindgut. So sympathetic supply of the hindgut is by the lumbar nerves, okay, and the parasympathetic supply is by the pelvic splanchnic nerves S1, S2, and S3. Okay, the artery is the inferior mesenteric artery. And what structures this supply? The distal one-third of the transverse colon to the anal canal just above the pectinate line. And whenever you have pain or any problem or any issue, okay, from the distal transverse colon to this pectinate line, you will always have a referred pain to the hypogastrium. Okay, very important. So pain for the foregut, whenever get a issue, okay, that includes a foregut, okay, the patient will always complains the pain of the epigastrium. Okay, whenever they get the acidity or any kind of this ulcer, okay, any kind of GI ulcer, they will always complain of the epigastric pain. Okay, whenever any issue involves the midgut, the patient will always complain of pain which is near the umbilicus. Okay, for the hindgut, whenever any issue happened to the hindgut, the patient will always tell you the pain is happening in the hypogastrium region. Okay, and these are the three structures. Any doubts so far?
Do we need to remember all those specific nerve roots?
Yeah, they can ask you especially this.
Okay.
They can ask you for this umbilicus part because it is supplied by the T10. So you need to know that T9 will be finished up to the part, up to this, up to duodenum. And after the T9, the part will be, this, the distal duodenum and the colon. So, you just kind of, for the anatomical purpose.
Okay.
Okay.
Yeah. Thank you.
You need to know that. Yes. Then needs to know about the midgut, which is the longest part. As you can see, okay, the midgut, this midgut is giving rise to these structures from the distal duodenum up to the 2/3 of the transverse colon, and these includes the distal duodenum, then the jejunum, then the ileum, then the cecum, then the ascending colon, and then the 2/3 of the transverse colon. Okay, so this midgut is kind of a very largest structure, among these three. Okay, so what happened during the 6th week of the development? This midgut, okay, it will be herniate out of the body through the umbilical ring. Okay, this midgut will be herniate out of the fetus body, okay, through the umbilical ring, and outside the body, the development of this midgut happen. Okay, and all of the development is around the superior mesenteric artery. Okay, especially the rotation process occur. Okay, so what happens at the 10th week? In between the 6th to the 10th week, okay, this midgut is rotated 90 degree. Very important. This midgut is rotated to 90 degree clockwise. Okay, because it is a largest structure, it just cannot accommodate like that in the fetus. So, the physiological herniation generally occurs at the 6th week of the development. Okay, and during the herniation process, what happened? The midgut will be herniated out of the body of the fetus through the umbilical ring, okay, and then rotate to the 90 degree. Okay, then at 10th week, okay, this midgut will be returned back to the abdominal cavity. Okay, and after returning back, it will again turn for another 180 degrees. Okay, so outside the umbilicus, it would be 90 degree counterclockwise, okay, which is in this direction opposite to the clock. Okay, then when it get inside the ring, inside the body again, once more 180 degree rotation will happen. So a total of 270 counterclockwise rotation happens of the midgut, and that's why you get the liver on the right side and the spleen on the left side. Okay, and all of these structures which are on the right are because of this part only. Okay, and yeah, so that would be a 270-degree total this counterclockwise rotation. Okay, and you need to also know that all of this rotation, okay, it happens around the superior mesenteric artery. Step 1 can also ask you this, okay, or they can check you for the for the options. They can they can mention that this this midgut rotate around the inferior mesenteric artery or the celiac artery or the superior mesenteric artery. So you need to answer the superior mesenteric artery. Okay. Yeah, that would be all about the midgut development. Any doubt?
No, thank you.
Okay. So now comes the ventral wall defect. That means the anterior defects in the abdomen. Okay. And all of these defects are because of the failure of rostral fold closure. Sorry, because of failure of lateral fold closure. Okay, mainly. Okay, if the rostral fold closure occurs, okay, then it can lead to the sternal defects that includes the ectopia cordis, in which a sternum is visible in case of rostral fold defect, which is towards the head. Okay, in case of a lateral fold closure defect, okay, you can have two scenarios, which is the gastroschisis and the omphalocele. Okay, and it is because of a lateral fold closure defect. When the caudal fold closure defect occurs, it can lead to the bladder access trophy, in which your bladder is visible from the eyes. Okay, because the wall around this bladder is absent. Okay, so you get the bladder access trophy in case of a caudal fold closure. In case of a lateral fold closure, you can have an omphalocele gastroschisis. In case of a rostral fold closure, which is towards the head, you can have a external defects like the ectopia cordis. Is that okay?
Yes.
And now we discuss about the lateral fold closure defects. Two defects are here, the gastroschisis and the omphalocele. Okay. In both of these defects, you can say that your the herniated midgut, which is a physiological herniation, of course, okay, it won't return back to the original position again. Okay, so it would be a failure of physiological herniation of the midgut, okay, to return to the abdominal cavity again. So one thing is a lateral fold closure, and second thing, the herniated midgut, it won't return back to the abdominal part again, right? So it can rise to both of the scenario, the gastroschisis and the omphalocele. For the gastroschisis, okay, you're having the extrusions of the abdominal content through the abdominal folds in the right side. Please note the location; it is very important. Stefan will ask you this location. Okay, the herniation of these contents will be the right of the umbilicus. Okay, it would be from the right, as you can see in this diagram also. This is our herniation. Okay, and it is on the right side of the umbilicus. This is umbilical stump. Okay, this is umbilical stump, and the herniation is on the right side. And you can see that all of the structures are coming out of the abdomens. Okay, extrusion of these structures are happening, and these structures are not covered by the peritoneum or any kind of amniotic membrane or covering. Okay, so not covered by any peritoneum, not covered by any amnion. Okay, they are just these all of these structures are kind of naked and you can see easily. Okay, now the associations, there is no chromosome associations. Okay, and that's why the prognosis is kind of very much favorable. Okay, you will do the surgery and you will correct these things. Okay, very important. So this is a gastroschisis. Then comes the omphalocele. Okay, in this what happens, the lateral walls will fail to migrate at the umbilical ring. These are the lateral walls. Okay, and same thing around there, these are the lateral walls. Okay, and these lateral walls, they fail to migrate at the umbilical part, at the umbilical ring. Okay, so you have a persistent midline herniation of the abdominal contents into the umbilical cord. Okay, and as you can see, all of these structures are surrounded by the peritoneum. Okay, so abdominal contents are kind of sealed in the letter O, as you can see, and that's why the name omphalocele. Okay, but the associations there because of associated with the trisomies like 13. And does anyone remember the trisomy 13 name?
Patau.
And for 18?
Edward.
Okay, so these conditions are associated with the Down syndrome and the Edwards syndrome, and along with the Packwood-Wiedemann syndrome. And does anyone remember the mutation in Packwood-Wiedemann syndrome?
WT1 or WT2?
Yeah, exactly. Okay, so WT1, WT2 mutations for the Packwood-Wiedemann syndrome, you will always have a Wim's tumor in the patient. Okay, so because they're associated with kind of a deadly diseases or deadly syndromes, I must say, that's why the the prognosis is never can never be very much favorable. Okay, so that's why omphalocele is more severe than the gastroschisis because of its associations. Okay, for the gastroschisis, you do not have any covering over these over this abdominal structures. Okay, you can see them very clearly coming out of the abdomen on the right side of the umbilicus. Okay, failure failure of the lateral fold closure, okay, at the right side of the umbilicus can lead to the gastroschisis. Okay, and failure of lateral walls to migrate at the umbilical ring, it can lead to the omphalocele. For the gastroschisis, you do not have any covering. For the omphalocele, you have a peritoneum covering. Okay, favorable. The prognosis is very much favorable for the gastroschisis because it has no associations. For the omphalocele, it has many associations like the trisomies 13, 18, Packwood-Wiedemann syndrome. That's why the prognosis can never be very much favorable. Okay, so any doubt?
No, thank you.
Okay. Then comes the congenital umbilical hernia. In case of umbilical hernia, okay, you have a failure of umbilical rings to close. Okay, in case of in case of omphalocele, lateral walls they're not migrating at the umbilical ring. Okay, but in this case, the umbilical ring is fold. Okay, but this umbilical ring is failed to close. Okay, so after the physiological herniation of the midgut. Okay, so now what gonna happen? There would be the herniation of the abdominal contents from the umbilical ring, but all of these abdominal contents, they will be surrounded by the skin. In these scenarios, you have the abdominal contents and they're now surrounded by the skin because and because of the failure of these walls to migrate at these locations, right? So no skin would be there. Okay, no anterior wall would be there in these locations, in these two conditions. But in case of a congenital umbilical hernia, you have this you have the you have the herniation of the contents. Okay, and these contents will be surrounded by the skin. Okay, so it is kind of a uh, you know a protrusion which is covered by the skin, you can say, a protrusion which is covered by the skin. Okay, a kind of bump on the on the abdomen. Okay, this is the congenital umbilical hernia, and it is associated with the Down syndrome and the hypothyroidism. If you guys remember, we have discussed the hypothyroidism scenario, right? And we have discussed how this the pot belly. Remember, guys?
Yeah, yeah.
This is the umbilical hernia. Okay, whenever you compress, the hernia will be kind of resolved, and as soon as the pressure inside the abdomen contents rise, whenever the baby cry or strain, okay, or something like that, the contents will again herniate out. So it is a kind of reducible type of hernia. Okay, and it is covered by the skin. So whenever step one describes a structure which is covered by the skin, okay, a kind of protrusion which is covered by the skin, that means it is a congenital umbilical hernia. Okay, whenever the protrusion is covered by a membrane, not by the skin, that means it is omphalocele. Whenever the protrusions they are not covered by anything, okay, not by any membrane, that means it is the gastroschisis. Okay, so they will ask you the causes. Okay, no specific cause for the gastroschisis. Trisomies 13, 18, and this Packwood-Wiedemann syndrome for the omphalocele, and the Down syndrome and this hypothyroidism for the congenital umbilical hernia. Okay, and if these defects are small, then they will be closed very spontaneously. Okay, so so it would be a soft and non-tender bulge at the umbilicus. They will present to like this: soft and non-tender bulge at the umbilicus. Okay, and this bulge will be increased whenever the abdominal pressure will increase, when the baby cry, when the baby strain. Okay, then this thing will be increased. So, any doubt so far?
No, thank you.
No.
Then you need to know about the tracheoesophageal anomalies. Okay, and the most common one is the tracheoesophageal atresia with the distal tracheoesophageal fistula. And as the name suggests, you're having the atresia of the proximal this esophagus. Okay, and the fistula is formed between the trachea and the esophagus distally. Okay, like this condition. This is the most common type. You're having the atresia or the atrophy of the proximal this esophagus. Okay, and having a formation of fistula between the distal esophagus and the trachea. This is the most common one. Okay, and these conditions are and similar to them, you can also have these kind of conditions where you have a pure a pure this tracheoesophageal fistula type. As you can see, in this case there won't be any kind of atresia. It's just a pure connection between the trachea and the esophagus. So this is a pure tracheoesophageal fistula type. Okay, in this scenario, as you can see, you're having the atresia of the esophagus completely without any fistula formation. So this condition is kind of a pure esophageal atresia type. So you have three conditions. Okay, either a pure esophageal atresia, okay, either a pure tracheoesophageal fistula, okay, or a condition in which you have the both the atresia as well as the fistula. Okay, three things: a pure esophageal a pure esophageal atresia, a pure tracheoesophageal fistula. Okay, and in third scenario, a mix of both these kinds. Okay, esophageal fistula, the esophageal atresia along with the distal tracheoesophageal fistula, and this is the most common type. In all of these scenarios, you can have a polyhydroamnios. Okay, because of this constriction part, the fetus won't be able to swallow the amniotic fluid, and and as a result, the volume of this amniotic fluid will be keep on increasing. Okay, so whenever you encounter a patient, okay, who is having having a gestation of like 20 weeks for say, but but their abdominal size is kind of for the 36 weeks or 32 weeks, let's say. Okay, when you measure the abdominal girth, the patient was was found to be having this size of like 32 or 36 week of gestation, but in actual she was only having a 20-week gestation. So that's how you know, because the abdominal girth is so much increasing, the patient can have a polyhydroamnios in utero. Okay, that's how the step one will present you the scenario of this polyhydroamnios. They will tell you the patient is having a gestation of 22 weeks or 23 weeks, but the abdominal size of 30 weeks or 36 weeks. Okay, so whenever the mismatching something like that happen, you will be know that this must be a case of a polyhydroamnios. And does anyone know how the amniotic fluid is formed?
Urine of the
Exactly.
fetus.
It is by the urine of the fetus. So by the urine, the fetus will form the amniotic fluid. Okay, and by this swallowing, this amniotic fluid will be going inside the body of the fetus, then to the lungs. Okay, and then finally again back by the urine. Okay, so if this pathway is inhibited kind of thing, okay, or disrupted, okay, then in that scenario you can have a polyhydroamnios. Okay, so drooling would be there because the fetus cannot swallow the saliva. Okay, so that so the drooling of the neonate will be happen. Choking can also happen. Okay, contents can go to the esophagus. Okay, because as you can see, the esophagus is kind of a trachea air. Okay, so all the contents will go to the esophagus. They will be they will be reflux out and they can go to the this trachea, right? So the choking can happen. Vomiting after a first feeding can happen because as you can see, there is no pathway for the food to go into the GI tract, right? all of the food will be start accumulating here, and then the reflux of all of these food content will happen and the patient will get the vomiting. Okay. The air in the stomach is very much visible. Okay. The air in the stomach will be very much increased, I must say. So you will get a prominent gastric bubble because all of the air from the trachea, okay, it can enter the esophagus, and by entering the esophagus, it can reach to the stomach. So you will get a prominent bubble. Okay. In case of a pure type, a pure esophageal atresia type, because as you can see, nothing can pass through this esophagus, not even the air. So you won't have any, any air in the stomach. A gasless stomach will be seen on the X-ray. While in a normal scenario, some amount of air sometimes pass through the esophagus, which forms a gastric bubble. Okay. So in normal X-ray of the patient, you will get a gastric bubble in the stomach. In case of a pure esophageal atresia type, you won't see any bubble. In case of a fistula type, okay, whether it is a distal fistula or a pure esophageal fistula, you will have a very prominent gastric bubble, and that would be visible on the X-ray, the abdominal X-ray of the patient. Okay, whenever the patient, whenever the patient aspires these content, the esophageal contents, what's gonna happen? Laryngospasms will occur, and that can lead to the breathing complications, right? So patient will get the cyanosis. Just after the first feed, if you're encountering a patient who is having this, the vomiting, cyanosis, choking, and the breathing difficulties and the respiratory the distress, I must say, that's how you immediately know that that this could be a case of your the tracheoesophageal fistula. Okay, you will do the bubble test. You will do the X-ray. You will have a prominent bubble. Okay. Second thing, you can also pass a feeding tube to the patient. Okay, and while passing the feeding tube, as you can see, the feeding tube will be stuck in the esophagus. It won't reach to the stomach, right? It won't reach to the stomach. So this thing can also be detected. Okay, the failure of passage of this feeding tube will also confirm the diagnosis of this tracheoesophageal fistula. So a clinical test will be the failure to pass the nasogastric tube through the this into the stomach. Okay, because it will be stuck in the esophagus, right? It cannot be go to the stomach. So this test will also be performed for the tracheoesophageal fistula. Any doubt so far?
No, thank you.
Similar to the the esophageal atresia, you also have the intestinal atresias. Okay, and just like the esophageal atresia, if you get any intestinal atresia, you can also have a polyhydramnios. Okay, because after passing through the stomach, okay, all of this will go to the intestine part, right? If any kind of a blockage happen in that part, okay, then what happened? The patient cannot swallow this amniotic fluid, okay, and the patient will get the polyhydramnios. So in these conditions also, patient can get a polyhydramnios. If the obstruction is very much proximal one, okay, then vomiting will be the most prominent symptom. Okay, and if this blockage is in the distal part, okay, then this constipation and the bloating will be the prominent symptom. Okay, so how a patient with intestinal atresia will present to? First is the bilious vomiting. Okay, second thing is the abdominal distension within the first 2 days of the life. Okay, so a bilious vomiting and the abdominal distension will be the characteristic features. If the atresia is very much proximal, okay, then you get the vomiting dominated symptoms. Okay, if the atresia is kind of very much distal, then you get the abdominal distension. Okay, so you have two atresias. One is a duodenal atresia and second is the jejunal or the ileal atresia. In case of duodenal atresia, you have a failure to recanalization. Okay, a failure to recanalization can lead to the duodenal atresia. Okay, you have a blockage, you have a physiological blockage in the in the duodenum. Okay, and that blockage must be recanalized before the birth. Okay. So if the failure of recanalization occur, the blockage will be persisted, right? That constriction will be persisted, and that can lead to the duodenal atresia. You will have a double bubble sign. Okay, first air is in the stomach and second air is in the duodenum, the proximal part. Okay, a dilated stomach and the proximal duodenum will be seen on the X-ray, and these conditions are associated with the Down syndrome. Okay, because the bile will be already mixed with all the food, the milk. Okay, because this atresia happened just after the ampulla of the waiter, right, where all of your pancreatic and the liver contents mix with the intestinal contents, right? So the patient will get the bilious vomiting because the bile is already mixed with the food, right? So a bilious vomiting would be there, abdominal distension, mild type, not severe type would be there, double bubble sign would be there, and it is because of a failure to recanalization. Okay, by birth, in a normal situation, you have the fetus will have this blockage in the GI tract already in the duodenum. Okay, and that blockage must be decanalized before the birth. If the failure happened, the blockage will be persisted, and that can lead to the duodenal atresia. Any doubt?
I have one doubt.
Yeah.
In congenital hypertrophic pyloric stenosis, do we get double bubble?
In congenital, no, you won't get because it is before the duodenum.
Okay, thank you.
Okay, then comes jejunal and the ileal atresia. In case of a jejunal and the ileal atresia, you're having a disruption of the mesenteric vessels. And does anyone tell me which artery supplying the jejunum and the ileal part?
Superior mesenteric.
Exactly. So you have a disruption. You're having a disruption of the superior mesenteric artery, and if the blood supply to the jejunum and the ileum is lost, you can have a atrophy, the necrosis of the jejunum and this ileum, right? So you have a ischemic necrosis of the fetal intestine. All of the content just after the duodenum will be absent. Okay, and then you have a very distal ileum present, which is kind of a um, loop around the vascular stalk. Okay, so a classical presentation of the patient will be a normal duodenum. Okay, absence of a large segment of the jejunum and the terminal ileum. Okay, and the ileum also, and the terminal ileum distal to the atresia will wind around the vascular stalk. Okay, so absence of a jejunum, absence of ileum, but the terminal ileum, it will be wind around the vascular stalk. This is how step 1 will describe you the case of jejunal and the ileal atresia. Okay, they can ask you what going to happen to the terminal part. Okay, and these are the ileocolic vessels to which this terminal ileum wind around. They can ask you this part, what going to happen to terminal ileum. They can describe you a patient who is having, who is having a bilious vomiting, who is having a very prominent abdominal distension, a constipation. Okay, abdominal pain would be there. So the patient will be persistently crying. Okay, and then they can ask you what features you will get, or they might describe you the features of the patient, and they can ask you what is happening with the terminal ileum, why this thing is happening because of a disruption of the blood supply, necrosis will happen. Okay, the area will get atrophied completely, and you will get a triple bubble sign. One bubble in the jejunum, one bubble in the duodenum, and one bubble in the stomach. You will get a triple bubble sign in case of jejunum and the ileal atresia, double bubble sign in case of a duodenal atresia. Okay. So any doubt on these two things?
No, thank you.
I have a question.
Yeah.
Why
To
do
ask.
we have three bubbles like in duodenal atresia? It is the air in the proximal duodenum and the stomach.
Yes.
But why in jejunal and ileal atresia we are seeing third bubble?
Some part of jejunum will be there, right? And it will be filled with the air. So one bubble. Secondly, you have the duodenum part. Bubble. Okay, the same air will fill in the duodenum. You will get the second bubble. In the stomach, the air can fill there. You can get a third bubble. That's why a three bubble sign.
Is there any obstruction before the jejunum?
No. Obstruction
It would
started at the jejunum. Okay.
it would be continuous. the air segment would be continuous, huh?
Okay, sometimes you can
Air
get the
follows.
continuous, sometimes you can get a triple bubble also. Sometimes you can get a continuous, but the X-ray, as you can see, will show the dilated loops completely. Okay, but many times you will always see you will also see the triple bubble sign. Okay, and this thing is mentioned in the emboss. I think 2 or 3 questions I've encountered on genome and the ideal traces. And in most of the questions, I mean, in all of 3 questions, they have mentioned this triple bubble sign. Okay, so you can get this triple bubble sign also. Okay. Is that okay? Please respond. Is that okay?
Yes.
Okay. Then comes the hypertrophic pyloric stenosis. And does anyone remember which drug can cause this condition? We have discussed that already in the microbiome.
Erythromycin.
Exactly, the macrolides and the azithromycin, or you can say the azithromycins. They can cause the hypertrophic pyloric stenosis. Okay, it is a most common type of gastric outlet obstruction syndrome in the infants. Okay, what you will see is a palpable olive mass in the epigastric region. Okay, then you can also see the visible peristaltic waves. Okay, you will get a non-bilious projectile vomiting, very important. A non-bilious and the projectile vomiting. Why non-bilious? Because this obstruction is before the ampulla of the waiter, right? And your bile is still not mixed with the intestinal contents. Okay, so because of the obstruction, you will have a continuous vomiting whenever the patient feeds. Okay, you will have abdominal distension also. You will have a non-bilious projectile vomiting. Okay, and why this thing is happening? Because of a hypertrophy of the pyloric sphincter. Okay, there are smooth muscles in the pyloric sphincters, right? And whenever the hypertrophy of these smooth muscles occur at the pyloric sphincter, what you can have is a hypertrophic pyloric stenosis. Okay, very important. These are associated with the exposure to the macrolides. Very important. Okay, it will present within 1 month after the birth or around 1 month, not instantly. Very much important. You will get this. You will get the presentation of symptom before the 1 month. Okay, not at the time of birth. Okay, because of the vomiting, you will be losing all of your electrolytes. Right, you will get the hypokalemia, hypochloremia, and the metabolic alkalosis because of loss of acid. All of the gastric acid will be lost in the vomiting and the patient will get the metabolic alkalosis. So hypokalemia, hypochloremia, and the this metabolic acidosis. It is all because of a smooth muscle hypertrophy at the pyloric sphincter. Okay, whenever you do the ultrasound, it will show a thickened and the lengthened pylorus. Treatment will be make a surgical cut on this pyloric sphincter so that this obstruction could be relieved. You will make a surgical incisions of the pyloric smooth muscles, which is also known as the pyloromyotomy. Pyloromyotomy. Okay. And when the RAS further get activated because of this volume contraction, okay, whenever you have a loss of volume, you will always have an activation of the RAS. The patient can also get a further hypokalemia. Also important thing. Okay. So any doubt on this HPS?
Uh, is the cause of hypokalemia only RAS, or is there any other reason also?
Vomiting and then the RAS.
Okay,
Vomiting
so
is the major cause. Vomiting is the major cause. You're losing all your electrolytes. Okay, and then because of a loss of this volume, you can also get a activation of RAS.
yeah, okay. Thank you.
Then you can also have a GERD in the newborns, and this is because of an immature lower esophageal sphincter. Okay, it is kind of very much normal for a baby to have a GERD. Okay, whenever the patient try to feed the baby, you know, where they can say that the baby will be vomiting out the milk 2-3 times daily. Okay, so the patient will get a small amount of milk reflex, and the mother can describe this as a the vomiting out of milk 2-3 times a day, every day. Okay, and this is because of a immature lower esophageal sphincter. Okay, because a very small amount of reflux is there. Okay, you won't get the failure of thrive. The growth and development of the baby will be absolutely normal. Nothing happened. It's just a very kind of normal thing because of an immature lower esophageal sphincter. With the time, okay, the esophageal sphincter will be matured completely and will be functional completely. Okay, so patient will get a normal thing. Okay, so resolution symptoms will occur by their own selves. Okay, no intervention is required. Okay, this is very much normal. The patient won't get any growth failure or failure to thrive. Okay, and how the mother can describe this condition, they will tell you that during the feeding, the baby will always vomit out 2 to 3 times, daily while feeding. So yeah, is that okay? The GERD of newborns.
Yeah.
Remember this. It is not a pathological condition. Kind of very much normal. Okay, then you have a pancreas and the spleen. Very important. First, you need to know how the pancreas is formed in your body. It is because of two things. One is the ventral pancreatic bud. Okay, and second is the dorsal pancreatic buds. Okay, and you guys know because the pancreas comes in, comes in between the esophagus and the duodenum. So it is a foregut drive structure. First thing, it is a foregut drive structure completely, right? And it is driven by two buds. One is the ventral pancreatic bud, and second is the dorsal pancreatic bud. During the development, this ventral pancreatic bud will migrate, okay, in a circular pattern. As you can see in a circular path, it will migrate, right, and it will reach to the dorsal pancreatic bud and fuse to it, making a complete pancreas. Okay, you need to know what structures are derived from the ventral pancreatic bud and what structures are derived by the dorsal pancreatic duct. Okay, the main pancreatic duct, just give me a second. Yeah, so we're here again. So the main pancreatic duct, as you can see in the diagram also, okay, it is derived by the ventral pancreatic bud. Okay, the uncinate process, which is this part, okay, it is also formed by the ventral pancreatic bud. So the uncinate process, okay, the main pancreatic duct, and the part of head of the pancreas. As you can see, this is the head of the pancreas, and the part of this head is formed by the ventral pancreatic duct. Okay, now for the dorsal this pancreatic bud, the part of the head, the body, and the tail part. Okay, the part of head, the body, and the tail part, and the accessory pancreatic duct, which is this duct. Okay, it is formed by the dorsal pancreatic bud. So a part of head, then body, then tail, and the accessory pancreatic duct. It is formed by the dorsal pancreatic bud, the uncinate process, a part of head, and the main pancreatic duct. These three structures are formed by the ventral pancreatic bud. Okay, and this the main pancreatic duct will be open in the ampulla of Vater, as you can see. Okay, this is the ampulla of Vater, and this main pancreatic duct will be open at this part. Okay, then you also have an opening in the duodenum for this accessory pancreatic duct also, which is the minor papilla. Okay, very much important. So you have now two conditions. One is the annular pancreas, and second is the pancreatic division. In case of an annular pancreas, you are having an abnormal migration. The migration is there, first thing, but you are having a very abnormal type of migration or the rotation. Okay, so now what's gonna happen? This pancreatic tissue will form a concentric ring, a circular ring, okay, around the duodenum. Okay, it will form a ring of the pancreatic tissue around the duodenum. Okay, and it is just near the uh, uh, as you can see, because this structure has to form the ampulla of Vater. So as you can see, this ring formation will be happen around the ampulla of the Vater, right? And as a result, the patient can get a non-bilious type vomiting. Okay, so if you encounter a baby who is having a non-bilious type of vomiting, abdominal distension, Okay, so you can think about the annular pancreas also. Okay, if the patient, if in the scenario they didn't would describe any kind of visual peristalsis or any kind of olive mass, which is for the hypertrophic pyloric stenosis, then you can also think about the annular pancreas. Okay, in this case, you will get the non-bilious vomiting. Why is happening? Because of abnormal migration or abnormal rotation. Then the second scenario is a pancreatic divisum in which you have a failure of the migration. Okay, and failure of fusion. Most importantly, a failure of fusion of the dorsal pancreatic bud and the main pancreatic bud. Okay, or the ventral pancreatic bud, and as a result, you have now two buds separately in the body of the patient, baby, right? This condition is mainly asymptomatic. Okay, but sometimes the compression of the duodenum can happen. Okay, and sometimes the pancreatitis can also happen because of this condition. Okay, and only in these scenarios the patient will be symptomatic. Okay, step one will ask you, because both of these buds are not fusing to each other. Okay, then where does the main pancreatic duct and the accessory pancreatic duct be open? Okay, so the ampulla of Vater will be opened for the ventral pancreatic duct. Okay, and the accessory opening will be present. Okay, for the dorsal pancreatic bud. So ampulla of Vater. Okay, this ventral pancreatic bud will be opening in the ampulla of Vater, which is a very major papilla. Okay, this dorsal pancreatic bud, it will be opening in the accessory the pancreatic duct in the minor papilla. Step one can also ask you this. Okay, and yeah, as you can see, this case, okay, there's a circling of the duodenum is happening, right? And because of the circling, what can happen is the annular pancreas. It can cause the constriction of the duodenum. At the second part, patient will get a non-bilious vomiting, abdominal distension, persistent cry, and yeah, that would be all. Any doubt on the pancreas?
No, thank you.
Now you need to know about the spleen. Okay, spleen is not derived by the foregut, midgut, or hindgut, or any of these embryological origin. Very important. Spleen is not derived by foregut, midgut, or hindgut. It is derived by the mesentery of the stomach. Okay, the mesentery, the lining, okay, which is around the stomach. Okay, it forms your spleen. Okay, and that's why the spleen is mesodermal structure, not the endodermal structures. Every GI organ or the path that you know, they're always the endodermal structure, except for the spleen. It is not derived by the foregut, midgut, or hindgut, so it is not an endodermal structure. It is a mesodermal structure because it is derived by the mesentery of the stomach. And because the mesentery of the stomach will be getting the same blood supply as that of the stomach, okay, and as a result, the spleen will be supplied by the foregut supply, which is the celiac trunk. Very important. The blood supply of the spleen is same as that of the foregut structures, which is the celiac trunk. The spleen has a separate arteries, the splenic arteries. Okay, but it is not derived by the foregut. Okay, it is a mesodermal structure. Any doubt?
No, thank you.
Okay, so we are done with the embryology section. Okay, and now we're moving forward for the anatomy of the GI tract. First, you need to know about the retroperitoneal structure. You have a lining in the in the abdomen, okay, which is known as the peritoneum. Okay, all the structures, all the organs which are present inside this peritoneum, you will call them the intraperitoneal structures, which are covered by the peritoneum or the lining of this mesoderm. Okay, all those structures which are behind the peritoneum, okay, which includes these structures, as you can see, the kidney part from this the areum lining. Okay, this all part is behind the peritoneum, and that's why you call them the retroperitoneal structures. So in a scenario wherever a uh, whenever the blood supply to these organs get compromised or some kind of a hemorrhage occur, okay, then you will always get a retroperitoneal hematoma in this scenario. Whenever a blood supply, which is supplying these organs, okay, will be ruptured, blood vessel will be ruptured, then you will always get the retroperitoneal hematoma. Okay. In case of intraperitoneal structures, if the vessel supplying there, they will get ruptured, then in that case you will have a hematoma within the peritoneum. So you will have a intraperitoneal hematoma. So step 1 will give you a history of a patient who is having a recent history of trauma. Okay, and now the patient is either having a retroperitoneal hematoma or the blood accumulation in the retroperitoneal space. Okay, or the patient can be having the intraperitoneal hematoma, and they will ask you what blood vessel could be ruptured in this patient. So they will give you a list of all the vessels. Okay, if it is a case of a retroperitoneal hematoma, then they will give you most of the vessels which are supplying the intraperitoneal structures. One will be to the retroperitoneal structure, and that would be the answer. In case of an intraperitoneal bleeding, they will give you a list of all the vessels which is supplying the retroperitoneal and the interperitoneal structures. You need to choose the intraperitoneal structure, anyone. Okay, so that's why you need to know what structures are retroperitoneal, and it is by the mnemonic Sadpucker. For the S, you have a suprarenal glands, the adrenal glands. Okay, the aorta from A, and as well as the inferior vena cava. So whenever you have any rupture in the aorta, or or any branch of the aorta, like the celiac trunk or the superior mesenteric artery or the inferior mesenteric artery or the esophageal artery, any major branch, I must say. So whenever you have a rupture of any major branch of the aorta, the bleeding will always be the retroperitoneal. Similarly, if you have any rupture in the inferior vena cava, the bleeding will be retroperitoneal. For the duodenum, second to fourth part, okay, that means I can say a distal duodenum, the distal half of the duodenum will be retroperitoneal. The pancreas, which is except the tail part, which is covered by the peritoneum of the spleen, okay, except this part, the pancreas is a retroperitoneal structure. Uterus, okay, then the colon, the ascending and the descending part. The transverse part is a intraperitoneal. And does anyone remember under which peritoneum the transverse part of the colon is accommodated, covered?
Could you please repeat once?
I said that the transverse colon is a intraperitoneum. Okay, so from which peritoneum, okay, this transverse colon is covered. The name of the
Greater
peritoneum.
mesentery.
Yeah, exactly. The greater omentum. Okay, the greater omentum. Okay, it will be covered. It will cover the transverse colon. Okay, but not the ascending and the descending colons, and that's why these two structures are retroperitoneal. Because the suprarenal glands are above the kidneys and they're retroperitoneal, the kidneys must be retroperitoneal also. Okay, the thoracic portion of the esophagus, it is retroperitoneum. The rectum, okay, is also retroperitoneal. So the Sadpucker, Sadpucker, you must remember this mnemonic and the structures which are retroperitoneal. It will help you identifying the cause of the bleeding on the south of and the site of the bleeding. Okay, that would be all from this part. Any doubt?
No, thank you.
And then you need to know all the ligaments between the liver, spleen, okay, stomach, and kidney. Okay. The first ligament is the falciform ligament. As you can see, this is the CT imaging of your liver. Okay, and you're seeing these structures from the toe of the patient, from the feet of the patient. Okay, you're looking on these structures from the feet of the patients, right? So this will be your right side, this will be your left side, this will be your superior part or the upper or the upward part, and this will be your base or the back of the patient. Okay, so the liver is on the right side, as you can see, and the anterior to the liver, okay, is a falciform ligament, okay, which is attaching or connecting the liver to the anterior wall. This is the anterior wall of your abdomen. Okay, and and connecting the liver to the anterior wall will be your falciform ligament. The umbilical veins, if you guys remember, the fetal umbilical vein, okay, which is supplying the placenta, they will be ultimately forming the falciform ligament. Okay, remember?
Yeah.
So it connects the liver to the anti-abdominal wall. The structures are the ligamentum teres hepatis, okay, which is derived by the fetal umbilical veins and the patent para-umbilical veins also. Okay, and they are the derivatives because they are ventral, as you can see. They are the derivatives of ventral mesentery. You have two types of mesenteries, the ventral mesentery and the dorsal mesentery. You need to remember which ligaments are derived by the ventral mesentery and which ligaments are derived by the dorsal mesentery. Okay, so this is about the falciform ligament. Nothing much. Okay. Then comes the lesser omentum. Okay, and this lesser omentum has two parts. One is the hepatoduodenal ligament, and second is the gastrohepatic ligament. As you can see, the ligament between the stomach and the liver, which is this ligament, this is your gastrohepatic ligament. Okay, and a distal part, or more on the right side, you're having one more ligament, which is the hepatoduodenal ligament. So two parts for the lesser omentum. One is the gastrohepatic ligament, this part, okay, and second is the hepatoduodenal ligament, which is this part. Okay, if you if you look anteriorly, then you're having this liver, right, and you're having this stomach, okay, like that. Okay, this will be your ligament, okay, which is the this is your lesser omentum. Okay, and it is formed by two parts. One is the gastrohepatic ligament, which is up to this part, okay, and second part is the hepatoduodenal ligament. Okay, very important. Now, for the gastrohepatic ligament, okay, it contains vessels, okay, which are for the uh, which supplies the blood to the stomach. Okay, so I can say that it contains the vessels which are supplying the stomach, the gastric vessels. Okay, for the hepatoduodenal ligament, okay, they contain the vessels, okay, for the portal triad. Okay, for the portal triad, you have the portal vein, okay, you have the hepatic artery, and one more structure, which is
Bile duct.
bile duct. Exactly. So all of these three structures, as you can see, the common bile duct, the portal vein, and the proper hepatic artery, they're all contained in the hepatoduodenal ligament. Okay, so two parts for the lesser omentum. One is the hepatoduodenal ligament, and second is the gastrohepatic ligament. The gastrohepatic ligament, it contains the structures that contain the gastric vessels. Okay, for the hepatoduodenal ligament, it contains structures like the portal triad, okay, which is the common bile duct, the portal vein, and the proper hepatic artery. Must remember thing. And these are also the derivative of ventral mesentery. Very important. They're also the derivatives of ventral mesentery. Okay, now you need to know about a Pringle maneuver. Very important, a Pringle maneuver. Whenever you have a bleeding in the in the abdomen, and you're suspecting that the bleeding could be from the portal triad, okay, either from the portal vein or either from the hepatic artery, then what you're gonna do, you will make a clamp at the hepatoduodenal ligament. Okay, you will compress this ligament because this ligament contains the vein and the artery. If the bleeding is stopped, okay, that means you can be damn well sure the cause of bleeding would be the portal triad, right? In case you are clamped you have clamped this ligament, but still the bleeding is happening. Even after clamping these vessels, this ligament, the bleeding is happening. That means the cause of bleeding is not the hepatic artery or the portal vein, but any other vein. It could be inferior vena cava or any other branch of the aorta, but not the portal triad. Okay, that's why you need to do the Pringle maneuver. Okay, to check for the cause of bleeding. Very important. I think that's all about the gastrohepatic and the hepatoduodenal ligament. Any doubt?
No, thank you.
Yes. Okay, and yeah, just give me a second. Okay, then you also need to know about the lesser sac and the greater sac. Just after you make an incision in the anterior wall of the patient, okay, you will first encounter, okay, you will make the incision in the anterior wall, you will cut the skin of the patient, you will cut the subcutaneous tissue, you will reach into the abdomen. Okay, as soon as you enter the abdomen, you will encounter a membrane, okay, which is a peritoneum, okay, containing within this peritoneum space, which is known as the greater sac. So everything that you are seeing here, this is all the greater sac out of the patient. This is all the greater sac that you're seeing here. Okay. So whenever you cut the anterior wall or whenever you make any incision in the abdomen, okay, the first thing that you encounter would be the greater sac. And every diagram of the abdomen that you see, okay, you're actually removed the greater sac already. Okay, very important. The liver you are seeing in the diagrams of any abdomen, the stomach that you are seeing, okay, all these ligaments that you were seeing in the the diagrams, they are they're all after the removing of this greater sac. Okay, so that you can see these structures very clearly, right? Then you also have a lesser sac. Okay, remember this ligament, the gastroduodenal ligament, the gastrohepatic ligament and the hepatoduodenal ligament. Behind this ligament, okay, you have the lesser sac, very important. Okay, and the anterior, and this the greater sac and the lesser sac will be communicating each other, okay, with a foramen, and this is known as the foramen of Winslow or the omental foramen. Okay, so you can you can put your hand in this lesser sac via this passage, as you can see this passage which I'm marking. Okay, and this is the passage for the foramen of Winslow to enter into the lesser sac. So you have two sacs. One is a greater sac and second is the lesser sac. Okay, and this lesser sac will be contained in the ligaments like the gastrosplenic ligament, splenorenal ligament, and the gastrohepatic and hepatoduodenal ligament. These four ligaments will be containing your lesser sac, as you can see very clearly. Okay, and behind this part, the peritoneum is overt in that part, and as you can see, okay, this is the last part for the peritoneum, and behind this part, every structure that you can see, the kidney, the aorta, the inferior vena cava, the part of pancreas and other things, they are all your retroperitoneal structures, right? Behind this peritoneum is your retroperitoneal structures. Okay, so peritoneum will be divided into two sacs, the greater sac and the lesser sac. Any doubt so far?
No, thank you.
Then you need to know about two more ligaments. Okay, three more ligaments. One is the gastrocolic ligament. Okay, and the name suggests it is between the gastrium, which is the stomach, and between the colon. Okay, and this is the greater omentum that you guys know. Okay, this is a this is the greater omentum, which is connecting the transverse colon with the greater curvature. And that's why I said that this transverse colon is an intraperitoneal structure, not a retroperitoneal structure. It contains the gastroepiploic arteries. Please remember this thing. It contains the gastroepiploic arteries. Then comes the gastrospleen ligament. As the name suggests, it is between the spleen and the stomach. This ligament, the gastrospleen ligament, it contains the splenic vessels. It contains the short gastric arteries, okay, and the left gastroepiploic arteries or the vessels, okay. It is also a part of a greater omentum, very important, and a part of your dorsal mesentery. See, up to the part of lesser omentum, the falciform ligament and the lesser omentum, they are the part of your the ventral mesentery, okay, the gastrocolic, gastrosplenic, and the splenorenal ligament. There are three other part of your dorsal mesentery, okay. For the gastrosplenic ligament, it contains the splenic, it contains the gastroepiploic vessels, okay. For the splenorenal ligament, which is between the spleen and the kidney, this ligament, okay, this one, it contains the splenic vessels now. Okay, the splenic artery, splenic vein, and the tail of pancreas. Remember, I told you the tail of pancreas will be covered by the mesentery or by the peritoneum of the spleen, right? And that's why the tail of the pancreas is the intraperitoneal structure. Okay, so 6 ligaments that you must remember. One is the falciform, the anterior one between the anterior wall and the liver. The laceromentum, which has 2 parts, the hepatoduodenal part and the gastrohepatic part. Okay, it contains the gastric vessels as well as the portal triad. Pringle manure, must remember thing. Okay, then the gastrocolic ligament that contains the epiploic arteries, the gastrosplenic ligament that contains the left gastroepiploic arteries, the splenorenal ligament which contains the splenic vessels. Okay, and these 3 are the part of these are the upper 2 are the part of your uh, the greater omentum. Okay, and all of these 3 structures will be driven by the dorsal mesentery. Okay, any doubt?
No.
Okay. Okay, now you need to know about the digestive tract anatomy. Okay, you need to know the layers of the gut wall. Okay, and we go from inside to outside. Okay, so first thing you will have the lumen, which is a space in the intestine. Okay, surrounding the lumen will be your mucosa. Okay, this mucosa contains the epithelium. Okay, the lamina propria, which is kind of a the stroma, you can say. Okay, then the muscularis mucosa will be also there, which is made up of muscles, of course, as the name suggests. So the epithelial part, the stroma, which is the lamina propria, and the muscularis mucosa, these are all the part of the mucosa. After the muscularis mucosa, you will have the submucosa. The submucosa contains the submucosal nerve plexus, also known as the Meissner's plexus, that secretes the fluid. So every fluid secretion that you guys know in the GI tract is because of the Meissner's plexus, or also known as the submucosal plexus. Okay, every artery, every vein, okay, they are all present in the submucosa, which is supplying the intestine. Okay, then comes the muscularis externa. Okay, it includes the muscles. 2 muscles are there. One is the longitudinal muscles, and second is the circular muscles. Circular muscles will be the inner ones, and the longitudinal muscles are the outer one. They are supplied by the myentic nerve plexus, also known as the Orphac plexus. And because it is supplying the smooth muscles, it can what they will cause the peristalsis. Okay, so the Orphac plexus is involved in the motility. The submucosal plexus or the Meissner's plexus is for the secretion. The Orphac or the myentic nerve plexus, it is for the mobility. Okay, the motility. Then comes the outermost covering, which is known as the serosa. Okay, and you call it serosa whenever the structure is intraperitoneal, and you call it adventitia whenever the structure is retroperitoneal. So so use these words very carefully. Okay, whenever you are describing a structure which is intraperitoneum, you will use the word serosa. Whenever you are describing a structure which is retroperitoneal, you will call this outermost covering as the adventitia. Okay, most of the ulcers, they will remain only up to the mucosa and the submucosa. Okay, sometimes they can also reach to the muscularis part. Okay, very important for the ulcers. Erosions that you guys know, they're always in the mucosa part only. So erosions are always in the mucosa, and ulcers, they can reach up to the this muscular layer. Okay, and as a result, the complete rupture can also happen, and that can lead to the bleeding complications in the ulcers. Whenever transmural rupture happen, that can lead to the bleeding complications in the ulcers. Okay, so any doubt on these layers?
I have one question.
Yes.
Is the peritoneum also made up of mesothelium?
Is the peritoneum also made up of mesothelium?
Yeah.
It is made up of mesodermal tissue, right?
Yes.
Sorry, I didn't understand completely what I had to ask.
Like there's a kind of cell called the mesothelium which makes the pleura also. So
Oh,
I'm asking if the same kind of cells are present in the pleura, in the peritoneum also.
same type of cells, but you won't call them the mesothelium, right?
Okay, okay.
You won't call it mesothelium. It is different. It is the thorax part only, right?
Okay, okay.
You will call it mesoderm, especially the peritoneum has a special name, not the mesothelium. Okay.
Yeah.
So
Okay.
different things.
Okay, thank you.
Okay. As you can see in the diagram also, this is the innermost lumen. Surrounding the lumens will be your finger-like projections from the epithelium. Okay. Just after the epithelium, you will have the stromal tissue. Okay, which is lamina propria. Okay. After lamina propria, you will have a very thin muscular layer known as the muscularis mucosa. Okay. After the muscularis mucosa, you will be having a submucosa, which is this yellowish part, as you can see. The submucosa contain the blood vessels, the nerve supplies, which is for the secretions. Okay. Every gland, every special type of gland that you know is in the submucosa part only. Okay. After the submucosa, you will have the smooth muscle part. The inner one will be the inner circular muscles. The outer one will be the longitudinal muscles. In between these two layers, as you can see, there would be our nerve supply, which is the Orbeck plexus or the mytic plexus. The outermost layer where the major arteries are present. This is the serosa. Okay, and just let me open my file. Just give me a second. As you can see on this histology of a normal intestine, okay, this is your lumen. Okay, after the lumen, you will have an epithelial layer, and the epithelium will be forming these villi, as you can see right here, right? In between these villi, all this tissue that you are seeing, this is the lamina propria. Okay, so lamina propria is not a very much specific layer, but in between every cell, you have this stromal tissue, right? And this stromal tissue is known as the lamina propria. If I zoom in here, as you can see, this is the epithelium. Okay, and just after the epithelium, I'm having this all this tissue right here. This is a stromal part, and this is known as the lamina propria. If I further zoom in here, as you can see, and this lamina propria contains the plasma cells, which are the antibody secreting cells. And does anyone remember the migration of the IgA antibodies?
Yeah, it's containing the secretory protein.
And what does this process called? Step one will ask you this, the name of the process by which the IgA antibodies migrate to the lumen. One. Anyone? Transcytosis, I think, right? Because yes,
Yeah.
transcytosis, don't forget. Okay, so plasma cells, they will secrete the antibodies into the lamina propria. You have these the epithelial cells here, right? These antibodies will cross all these epithelial cells all the way back, okay, and they will enter into this lumen space, right? And where they can act on the microbes, right? So don't forget that. So lamina propria, it is present in between the cells, okay? Every tissue that you are seeing here, all of this area is the lamina propria. Then you have a very thin muscular layer, as you can see here, a very thin muscular layer. If I zoom, as you can see this part, this is known as the muscularis mucosae, a very thin muscular layer, muscularis mucosae. Then after this part, there will be your submucosa. The submucosa contain the blood vessels, as you can see, or this the reddish part, as you can see, filled with the RBCs. These are the blood vessels, as you can see. I'm circling, right? These are the blood vessels, and these are all present in the submucosa. A special type of glands, if there's somewhere in the GI tract, then they're also present in the submucosal part. Okay, very important. After the submucosal, you will have the muscularis part. Okay, which is the 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 inner part will be the circular muscles, and the outer one will be the longitudinal muscles. Okay, the muscularis externa. Then finally you will have the serosa. Okay, and yeah, that would be similar thing for the stomach, right? You can see all these linings, the epithelial lining. This is all the lumen. Okay, this is the epithelial lining, as you can see. Okay, and in between the epithelial lining, you have the lamina propria again. Okay, then you have this muscularis mucosa, very thin layer. Okay, after the muscularis mucosa, this complete part is the mucosa. You will have this muscularis mucosa. Then you have the submucosa. Okay, and this submucosa contain every nerve. Okay, for the secretion, and the blood vessels, as you can see, they're also present in the submucosa after the muscularis part. Okay, yeah. So any doubt on the histology or the digestive tract anatomy so far?
No, thank you.
So we are back to this FAI first aid again. Okay, so submucosa, muscularis externa, and the serosa. It is not just a kind of thing. You have the epithelium, and then you have this and then you have this lamina propria. It is not a specific layer. In between every cell, you have the lamina propria. Okay, very important. Then you need to know the frequency of basal electrical rhythms, okay, which are generated by the interstitial cell of Cajal. Very important. Interstitial cells of Cajal, okay, they make a basal electrical rhythm. Okay, they will generate 3 waves per minute in stomach, 12 waves per minute in duodenum, and 8 to 9 waves per minute in the ileum. Very important. Okay, so just like your heart, okay, where you have a spontaneous beat, okay, you also have a spontaneous rhythm in case of intestine also, and these are generated by the interstitial cells of Cajal. Okay, very important. Then you need to know the specific histologies of different organs in the GI tract, and one is the esophagus. Okay, the epithelium of the esophagus is non-keratinized, stratified squamous epithelium. Okay, non-keratinized, stratified squamous epithelium. The upper one third, the upper one third part, it contains the striated muscles, which are under your voluntary control, the skeletal muscles. The lower and the middle, the complete 2/3 part, okay, it contains the smooth muscles, and some overlapping will be there at the transition. Very important. So in case if you have a dermatomyositis or the polymyositis, okay, because these are the conditions, they were affecting your skeletal muscles, so they can affect the esophagus, the upper 1/3 of the esophagus. They can cause the inflammation in the upper 1/3 of the esophagus, right? Where if you have a condition which is affecting a smooth muscles, and doesn't anyone remember the name? Similar to dermatomyositis, polymyositis, you will also have an inflammation of the smooth muscles. Anyone? Where you have a lots of collagen deposition and the destruction of the smooth muscles. No?
Like Crest syndrome?
Yeah, Crest syndrome, scleroderma, right? In the scleroderma, you will having a smooth muscle atrophy, right? And the smooth muscles are present in the lower 2/3 of this the esophagus, right? So in case of scleroderma, you will be affecting your lower 2/3 of the esophagus. In case of dermatomyositis or this polymyositis, you will be affecting your esophagus in the upper 1/3 part only. Don't forget that. Okay. You will get a dysphagia whenever the striated muscles will be affected. You will get the GERD or the reflex disease whenever the this middle and the lower part will be affected, along with the dysphagia, of course, because the sphincter is also made up of smooth muscles, right? So you will get the GERD, you will get the dysphagia in case of dermatomyositis, in case of scleroderma. You will get the only dysphagia in case of dermatomyositis and polymyositis because of these conditions. Okay. And yeah, that would be all. Any doubt on the esophagus?
No, thank you.
Okay, then we have discussed the histology of the stomach already. Okay, as you can see, also again, for the stomach, you have kind of two layers. Okay, the upper layer and the lower layer. Okay, then you also have the pits. As you can see, you will have the pits. Then you will have the glands. Okay, first you will have the pits, then you will have the glands. Superficial layer will be there and a deep layer will be there. So superficial glands are there and the deep glands are there. Okay, and does anyone remember which glands are in this upper glandular layer and which glands are in the deep glandular layer? Anyone? No? The chief cells, okay, which secrete the pepsinogen, they are found in this deep glandular layer. Okay, very important. And the parietal cells, which secretes your HCl, okay, they are found in this upper glandular layer. Okay, and the mucin secreting cells, which are the mucous neck cells, they are forming these pits. As you can see, these pits are formed by the mucous neck cells. Okay, the superficial glands, which are mainly made up of these parietal cells. Then the deep glands, which are made up of this the chief cells. Okay, this is the histology we get in the stomach. Is that okay? If I again open my file, just give me a second. As you can see, these are the pits. Okay, these are the pits, right? Then you have a superficial glandular layer, and then you have a very deep glandular layer. If I zoom in, then I can see that very clearly. All of these cells are lined by the, all of these layers are lined by the columnar cells. Okay, and these are the mucous neck cells. You will see, right? Then you have the glandular layers. Okay, if I zoom into this to these layers, you will have the parietal cells, which are kind of this eosinophilic, as you can see. The parietal cells are eosinophilic, very much pinkish, and the chief cells are very much bluish. And these parietal cells, they will have these granules. So all of these granular cells that you are seeing, this cell, and these ones, every granular cells that you are seeing here, these are the parietal cells. And the basophilic, a kind of bluish cells that you are seeing in the histology, these are the chief cells. Okay, step one will give you the histology of a stomach. Okay, and they will ask you to mark the parietal cells. They will give you a function of certain cells, and they will, and they will ask you, after giving a histology with some arrows, that which of this following secretion is secreted by, which kind of cell, right? So they will mark the arrows in the histology, and you need to answer which cell is a parietal cell and which cell is the chief cell. So you must know that chief cells are always much more in the deeper layers than the parietal cells. First identifying feature. Second identifying feature, chief cells are much more basophilic in the nature, much more bluish, while the parietal cells, they are much more eosinophilic in the nature, and a very granular appearance will be there. Okay, for the mucin neck cells, they and because they are rich in the mucin, okay, they are very much clear, as you can see. Okay, they are very much clear and a very hazy cytoplasm. You can describe that as. Okay, as you can see, this is the nucleus, this is cytoplasm, very much clear cytoplasm in every cell you can see. These are all the cells which are filled with the mucin. Okay, and in between these cells, you will have the lamina propria. This is all the lamina propria. Is that okay for the stomach?
Yes.
Histologies are so much important, they will ask you this. Okay, so please note. So then comes a duodenum. Okay, duodenums are the villi, the microvilli, which increase these absorptive areas. Then they have a very special type of glands which are known as the Brunner's gland. And these are the bicarbonate secreting glands which are found in the submucosa. They are found in the submucosa, very important. And they also have a crypts of Lieberkühn. Okay, and these crypts, okay, these crypts, so this part, lower part, okay, these crypts will be containing the stem cells. And these stem cells from the crypts, they will replace all these epithelial cells. Okay, they will replace the enterocytes, the goblet cells, and the Punnett cells. Punnett cells are very important because these are kind of a cells which are which are involved in the immune response. Okay, they secrete the antibacterial enzymes that control the microbial flora. Okay, so these are the Punnett cells which are found in the mucosa. Okay, so please remember the function of the Punnett cells and the Brunner glands and the location of these glands. Some mucosa are very important. These are, these are very much circular glands that you will see in the submucosa. So whenever you encounter a histology of a patient, which is having a circular kind of glands in the submucosa, that means it is the Brunner's gland and the histology will be of your duodenum. Okay. Then comes the jejunum, which has a placa circularis. Okay, these are the folds of the muscles. Okay, nothing much more. And then the ileum part, and the identifying feature of the ileum is the presence of pair patches, which are the lymphoid aggregates in the lamina propria as well as submucosa. So major part will be in the submucosa, and because you know that the lamina propria contain the immune cells, the lymphocytes, and this, what you say, the plasma cells, right? They contain these cells. So they must be connecting to the they must be connecting to the pair patches, right? So the pair patches will be in the lamina propria as well as in the submucosa. Plica circularis will be present, which are the folds of muscles. Okay, and the crypts of Lieberkühn are also present. And you have a largest number of goblet cells in the small intestine. Does anyone know the function of these goblet cells?
Secretes mucus.
Exactly. So do not confuse between the Brunner's gland and the goblet cells. Goblet cells are for the mucus. Brunner's glands are for the bicarbonate. Okay, very important. Then for the colon, you do not have any much more villi to increase this area, but you have an abundance of these goblet cells. As you can see in the histology also, you will have the abundance of the goblet cells without any villi. Okay, so if the Stefan shows you a histology of a patient or a segment of the intestine which has no villi but and abundant goblet cells, that means these are the histology of the colon. Okay, if they give you a histology having some circular glands in the submucosa, that means the duodenum. If they give you a histology in the patient having this kind of lymphoid aggregates, okay, that means it is for the ileum. Okay. So yeah, I think it would be all about it. Okay, any doubt?
Yeah, I have one.
Yes.
What is plica circularis?
See, when you see the intestine from from any endoscope, okay, this is a lumen of the intestine. Okay, if I see the intestine with some endoscope, what I can see some folds like structure. Okay, these folds like structure I will see, and these are the plica circularis. Okay, if this is the lumen, complete lumen, okay, then you will have some fold of structures like that. At some places they will be present, at some places they won't be present. Okay.
Yeah.
These are the plica circularis. These folds are very specific for the jejunum and the ileum. If you do the endoscopy of a duodenum, you will have very smooth transition, like this part only, no obstructions, right? But in case of jejunum and ileum, when you do the endoscopy, you can see some folds in the mucosa, some folds in the lumen, and these are the plica circularis.
Okay, that's basically something similar to Schatzki rings in the esophagus.
Yeah, exactly. Something like that.
Okay, thank you.
Okay, so any more doubt on this page? Up to this part?
No, thank you.
Then you also need to know about two type of glands in the stomach. Okay, one which is found in the body, or I can say the and one which is found in the pylorus. Okay, the ones which are found in the pylorus are known as the pyloric glands in the stomach. The ones which are found in the body of the stomach, these are the oxyntic glands. Okay, the pyloric glands, they have a surface mucus cells as a normal gland. Okay, then they have a mucus neck cells. Then they have the delta cells, and these delta cells are for the somatostatins. Okay, similar delta cells you also have in the pancreas part, right? And same delta cells are also for the are also in the pyloric glands for the somatostatins. Okay, and because you guys know that the antrum is the location, or the pyloric part is the location for the synthesis of the gastrin, so you will also have the gastrin secreting cells in the pyloric glands, and you have some endocrine cells also. So this is the pyloric gland. If you do the histology of a patient at the pyloric part, you will see these glands. Okay, they are very much branched ones. Okay, not tubular, but they are very much branched. They will have the delta cells and the gastrin cells. For the oxyntic cells, they have the mucus secreting cells. Okay, then in the upper part they have the parietal cells. Okay, not the gastrin cells, but they have the parietal cells which secretes the which secretes the HCl and the intrinsic factors. Okay, in the upper glandular layer they also have the mucous neck cells which forms the pits, of course. Okay, then you have the deep glandular layer. Okay, and in the deep glandular layer they have the delta cells, a very few delta cells, not as much as in the pyloric glands, very few delta cells, and many more chief cells. So chief cells are found in the deep layer, the deep glandular layer, and the upper layer you will have the parietal cells and the mucous neck cells. In case of pyloric gland, you will have the gastrin and the delta cells for the somatostatins, not the chief cells or the parietal cells. Okay, so this is a differentiating features between the pyloric gland and the oxyntic glands. Do not confuse between these two. Okay, locations are very much important, and whenever you have a H. pylori, okay, what did this H. pylori do? It will cause a destruction of the delta cells. Okay, the H. pylori causes the destruction of the delta cells, and as a result, the gastrin levels will be very much rising in the stomach. And when the gastrin levels are rising, they will cause more acid production in the stomach, and that can cause the duodenal ulcer. Okay, so this is a significant thing which you can correlate with the H. pylori. Okay, so any doubt now?
No, thank you.
Okay, we will take a short break of 10 to 15 minutes and then meet again. Okay.
Okay.
Okay, so we have discussed the anatomy and the histology of the GI tract, and now the branches of the aorta. Okay. Very important to note the level of the bifurcation of the aorta into the common iliac arteries, and it is the L4. And this is a very important thing. At the L4, the aorta will be divided into will be branched into the right common iliac artery and the left common iliac artery. Okay, this is the most important one. Now the aorta, first of all, it will give the phrenic branches, the inferior phrenic branch, and then the superior suprarenal, okay, which is for the adrenal glands. Okay, then at the level of the celiac artery, the aorta gives two middle suprarenal gland, two middle suprarenal arteries. Okay, the celiac artery as a T1 at the T12 location level. Okay, after the celiac artery, there is the superior mesenteric artery. Very important. Okay, just after superior mesenteric artery, okay, the aorta will be divided into the renal branches. Two renal branches will be given for each kidney. Okay, and the inferior suprarenal branch. So three arteries which are supplying your adrenals. Okay, one is the superior suprarenal, second one is the middle suprarenal, and third is the inferior suprarenal artery. So three arteries for the adrenal glands: superior, middle, and inferior suprarenal. Okay, then the renal arteries. Just after renal arteries, okay, the artery will give of the gonadal branches, okay, which is for each ovaries or the testes. Okay, then comes the inferior mesenteric artery. Okay, and just after the inferior mesenteric artery, the aorta will be divided into the right common iliac and the left common iliac artery. Okay. And know the location of this inferior vena cava, which is right to the abdominal aorta. Okay, this is the left, this is the right part. So inferior vena cava is right side of the aorta. So as you can see, because if this inferior vena cava drains the blood from the kidneys, right? So that this left renal vein must be longer than the right renal vein because it is more on the right side than on the left side, right? So left renal vein has more length than the right renal vein. Another important thing. Okay, and these veins will be anterior to the aorta. Okay, and you need to know that that the left renal vein will be between the superior mesenteric artery and the aorta. It passes between the superior mesenteric artery and the aorta, as you can see in this diagram. This is a superior mesenteric artery. This is our aorta, and this is the passage of your left renal vein. Okay, sometimes what happened, this left renal vein can be can be compressed in between the superior mesenteric artery and the aorta. Okay, and different scenarios can happen. We will discuss them shortly. Don't worry, right? Okay, and you also need to know some locations where you have a dual brittle supply. Okay, one is the splenic flexure. The superior mesenteric artery and the inferior mesenteric artery supplies the splenic flexure, but the distal branches of the SMA and IMA supplies there, and as a result, it is a watershed zone. Okay, it is a watershed zone because it is supplied by the distal branches. So whenever a blockage happened, the distal areas will be affected first, which is the splenic flexure. Then you have the rectosigmoid junction, okay, in which the superior mesenteric artery and a branch of the superior mesenteric artery. See, not superior but the inferior. Sorry, the inferior mesenteric artery and a branch of inferior mesenteric artery. Okay, they make the anastomosis at the rectosigmoid junction, and the end branches will be supplying this area. So it is also a colonic. So it is also a watershed region. Okay, so whenever a blockage happened in the inferior mesenteric artery, this rectosigmoid junction will be the most commonly or first affected area, right? Very important. So both are the branches of inferior mesenteric artery which are anastomosing at the rectosigmoid junction. Okay. So any doubts so far about the branches and these two areas?
Could you explain the anastomosis at rectosigmoid junction once again, please?
See, you have an inferior mesenteric artery, right?
Yes.
And this inferior mesenteric artery gives off a branch. Okay, this is the superior rectal artery. You have three branches for the rectal. You have three arteries supplying the rectal area: the superior, middle, and the inferior one. The superior rectal artery supplying the rectosigmoid junction and the superior part of the rectum. Okay, the middle rectal artery, which is supplying the middle 1/3 part of the rectum, just above the pectinate line, and below the pectinate line, it is the inferior rectal artery. Okay, so three rectal arteries supplying the rectum or the anal canal, right? So the superior rectal artery is a branch of inferior mesenteric artery, which is supplying the rectosigmoid junction and the superior 1/3 of the rectum.
Yeah.
Okay, and this artery, along with the branch of, along with the another branch of the inferior mesenteric artery, they both form the anastomosis in the rectosigmoid junction. Okay.
All right.
So this is okay. So both are the branches of IMA which are forming the anastomosis. For the splenic flexure, two different arteries, SMA and the IMA, they supplies the splenic flexure. Okay, very important.
Okay, got it. Thank you.
Okay, now comes two syndromes because of a blockage of this vein in the duodenum. One is the nutcracker syndrome and second is the superior mesenteric artery syndrome. Nutcracker syndrome happens whenever the left renal vein, which is passing between the superior mesenteric artery and the aorta, compressed in between two structures, the SMA and the aorta. So it will be present as an abdominal, or you can say the flank pain whenever you have a renal issue. Okay, whenever the step whenever the step one describe you a pain which is in the flank region, you can be 100% sure that this condition is involving the kidneys. Okay, because whenever the patient having a kidney issue, they will always have a flank pain. Okay, so the patient will have a flank pain. Patient will have a hematuria from the rupture of these thin vessels. Okay, And because you also know that your the gonadal vein, the left gonadal vein, it will drain the blood directly into the left renal vein. Is that okay?
Yeah.
The left gonadal vein, it will drain the blood into the left gonadal, the left renal vein, right? So due to the blockage of this left renal vein, the patient can also have a varicocele, a worm of bag-like appearance. Is that okay?
Yeah.
So varicocele would be there, flank pain would be there, and the hematuria would be there. Okay, and these are all the things you will look for the nutcracker syndrome. Okay, very important. Second syndrome is the superior mesenteric artery syndrome. Okay, it happens because of a blockage or obstruction or the compression, I must say, the compression of the duodenum between the superior mesenteric artery and the aorta. Okay, you have some visceral fat in between the duodenum and the superior mesenteric artery. Okay, which kind of prevent this compression of the duodenum. In a scenarios where you have a very rapid fat loss, okay, like exercising or or the low body weight or the malnutrition, okay, or the dieting, in that scenario you will have a very diminished fat in between the duodenum and the superior mesenteric artery, and as a result the angle will be reduced. Okay, and now the transverse part of the duodenum, okay, the transverse part of the duodenum will be compressed between the superior mesenteric artery and the aorta, and because of the compression you will have first the vomiting, okay, which is the bilious type vomiting, of course. You will have the abdominal distension, you will have the abdominal pain also, right? Very important. So symptoms will be intermittent, or I can say the episodic. Okay, sometimes you get the symptoms, sometimes patient will be asymptomatic. Okay, symptoms are or because of the obstruction of this duodenum. Okay, and yeah, so bilious vomiting would be there, constipation would be there, abdominal distension would be there, abdominal pain would be there, and it happens to the patient with low body weight mass, okay, and the malnutrition. It could be an actress, okay, which is doing exercise for the new role. It could be a patient with anorexia nervosa, okay. It could be other patients also. So any patient with a rapid fat loss, low body weight, or the malnutrition, they can this SMA can happen. The SMA syndrome can happen to them. Okay. So the difference between the nutcracker syndrome and the supramesenteric artery syndrome, do not confuse between the two. Okay. Sometimes in the supramesenteric artery syndrome, you can also have a compression of the renal vein also. Okay. So both of these symptoms can occur at the same time. Okay. So any doubts so far?
No, thank you.
Okay. And these are the blood supply to the rectum, the superior rectal artery, the middle rectal artery, and the inferior rectal artery. The superior rectal artery, which is a branch of inferior mesenteric artery, the middle and the inferior rectal artery are the branch of internal iliac artery. Okay, very important to note. Just keep this in your mind. Okay. Then you need to know about the branches of the external iliac artery and the internal iliac artery. Okay. For the external iliac artery, so you will first have this is a common iliac artery. Please mind my diagram. Okay. Okay. So this is a common iliac artery. It will be divided into the internal iliac and the external iliac. Okay. Now the external iliac, before this ligament, okay, before this inguinal ligament, it will gives a branch which is known as the inferior epigastric artery. Okay, inferior epigastric artery, which supplies the lower part of the anterior abdominal wall, the anterior part of your abdomen. Okay, in the lower part, it is supplied by the inferior epigastric artery, and in the upper part, it is supplied by the superior epigastric artery. Okay, so two epigastric arteries, superior and the inferior, which are supplying your anterior part of the abdomen. Okay. Then you have the deep circumflex artery, okay, which passes in, which passes under this inguinal canal, or I can, sorry, not the inguinal canal, but the inguinal ligament. Okay. This branch will be after the artery passes the inguinal ligament, and shortly after this, this external, this iliac artery, when passes the inguinal ligament, it will gives off a branch which is known as the deep circumflex iliac artery. Okay, it supplies the abdominal vein to the lateral part. So anterior abdominal part for the epigastric vessels, and the lateral abdominal wall is by the deep circumflex iliac artery. Okay, then you have once more the superficial epigastric artery also, which is also supplying the lateral wall in the very superficial area. Okay, so three branches. Okay, one is the inferior epigastric, second is the superior epigastric, okay, and third is the deep circumflex iliac. Okay, inferior epigastric supplying the anterior wall of the abdomen. Okay, deep circumflex iliac and the superficial epigastric supplying the lateral wall of the abdomen. Okay, very important. So step one will give you a some kind of angiography of the patient. Okay, and they will mark the arrow of some artery, and they will ask you what this artery could be, where does it supplying. So you must know the name of all these arteries, where they are originating, okay, under which structures they are passing through. Okay, before the inguinal ligament, it will be the inferior epigastric artery. After the inguinal ligament, it would be the superficial epigastric and the deep circumflex iliac. Okay, so any doubt on this external iliac artery?
No, thank you.
No,
Then,
thank you.
then comes the branches of the internal iliac artery. Okay, and you have the superior gluteal, inferior gluteal, okay, and the obturator. These are the three major ones for the internal iliac artery. Okay, these are the three major branches for the internal iliac artery: superior gluteal, inferior gluteal, and the obturator. Then other branches for the uterus, okay, for the perineum, okay, these branches will also originate. Okay, but these three are the major arteries from the internal iliac artery. Okay, and whenever you make a cut just below the arcuate line, okay, which is after your umbilicus, okay, just below your umbilicus you will have the arcuate line. Okay, if you cut you know if you make a transection just below the arcuate line, then a very high chances are there to cause the injury to the inferior epigastric artery. If you make a transverse cut just below the arcuate line, in case of a cesarean section, okay, then very high chances are there to cause a damage to the this inferior epigastric artery. So this inferior epigastric artery must be ligate before the cesarean section. Very carefully you need to ligate this artery just before the cesarean section, okay, because of risk of damage. So it is another important thing to remember. Okay, so any doubt on this page so far?
No, thank you.
We have discussed this table already. Foregut, midgut, and hidegut, the artery supplies we have discussed. Okay, the parasympathetic supplies we have discussed. The vertebral, the levels we have discussed, and the sympathetic supply we have also discussed, right? And which sympathetic supply for the foregut?
Splanchnic nerves.
Which splanchnic nerves?
T2 to T9.
Which splanchnic? It is pelvic splanchnic nerves.
No, lesser splanchnic.
Okay, and these are the branch of which nerve? Thoracic region. Okay, thoracic splanchnic nerves. Remember that thoracic splanchnic nerves supplying the foregut, okay, up to the level T9. Okay, from T9 to T12, thoracic splanchnic nerves, they are supplying the midgut. Okay, and the lumbar division, which is L1 and L2, they are supplying the hindgut. Okay, for the parasympathetic, up to the midgut, you will have the vagus nerve. For the hindgut, you will have the pelvic splanchnic nerves. Okay, the structures we have discussed: the pharynx, the lower esophagus, duodenum, liver, gallbladder, pancreas, and spleen. All of them are for the celiac arteries. Then distal luteum and the proximal 2/3 of the transverse colon for the superior mesenteric artery. Then distal transverse colon to the upper portion of the anal canal just above the pectinate line for the inferior mesenteric artery. Okay, then you need to know the about this celiac artery or the celiac trunk. Okay, this diagram, this figure is very much important. Okay, they will ask you the after after arrowing some artery, they can ask you the name, they can ask you the location, they can ask you the structures the artery supplying, they can ask you what happens if the artery get blocked. Okay, same thing goes for the venous for drainage also. Okay, they will block some vein and they will ask you what symptoms can happen to the patient, or blood supply to what organ, or ischemia to what organ can happen. Okay, what organ can get the this edema thing. Okay, or the venous congestion happen in which organ if I block this artery. So these kind of scenarios can be made on the celiac trunk and the venous drainage. For that, you must remember which artery supplying which structure, okay, and originating from which artery. They can also ask you if if some tumor is located in this in the liver, and I want to visualize a tumor with some kind of a dye. So they will ask you, where should I inject the dye? Okay, is it in the common hepatic artery? Is it in the celiac trunk? Is it in the proper hepatic artery? Okay, so where should I inject the dye so that it can go to the liver only? Okay, so these kind of scenarios can be made. For that, you need to know the arteries and the structures that they are supplying, right? So you have the celiac trunk, okay, and the celiac trunk will give off three branches. Okay, one is the left gastric branch, the major one. Second one is the splenic branch, and third one is the common hepatic branch. This is the common hepatic, this is the left gastric, and this is the splenic branch. Okay, the left gastric arteries, they also give some short esophageal branches. Okay, left gastric arteries will give the esophageal branches and also supply this part of the stomach. As you can see, this part of the gastrium will be supplied by the left gastric artery, okay, along the lesser curvature, I must say. Okay, then for the splenic artery, they give the short gastric arteries, okay, and they give the branch to the epiploic. Okay, this is known as a the gastroepiploic branch. Okay, it is from the splenic artery. And finally, the splenic artery will give the vessels and give the arteries to the spleen. So three structures: the stomach around the greater curvature, okay, which is by the two branches, the short gastric branch and the left gastroepiploic branch, and then to the spleen by the proper splenic arteries. Okay, for the common hepatic artery, if it gives off the proper hepatic artery, okay, and the gastroduodenal artery. Now, as the name suggests, it is gastro and duodenal, supplying the gastric structures and the duodenal structures. Just at the bifurcation, it also gives off a branch which is known as the right gastric artery. Okay, so left gastric artery is a direct branch of celiac trunk, and the right gastric artery is a branch of common hepatic artery. Okay, then you have a proper hepatic artery which is supplying the liver part only. Okay, it would be supplying the left lobe of the liver and the right lobe of the liver. Okay, left lobe of the liver supplied by the left hepatic artery, right lobe of the liver supplying by the right hepatic artery. Then you have you also have an artery for the gallbladder which is known as the cystic artery. If a blockage of cystic artery occur, it can lead to the it can lead to the cystitis. Okay, very important. Then for the gastroduodenal branch, okay, it will give off a pancreatoduodenal artery. Very important. It will give off a pancreatoduodenal, which means the artery supplying the pancreas and the duodenum, and it will cover and it will also give a right gastroepiploic. So right gastroepiploic is a branch of gastroduodenal artery, and left gastroepiploic is a branch of splenic artery. Okay, the gastric artery is already a branch of celiac trunk. Okay, and the right gastric artery is a branch of common hepatic artery. Okay, you have two arteries for the pancreaduodenal, the anterior one and the posterior one. Okay, yeah, that would be all. So any doubt on this supplies?
No, I think it's cool.
Okay, just give me a second. Okay, then the anastomosis between the midgut and the hindgut. Okay, first, the supramesenteric arteries and the inframesenteric arteries, okay, they gives off a branch which are known as the marginal artery of Drummond. Okay, very important. These arteries gives off a branches known as the marginal arteries of the Drummond, and the anastomosis happens in between the marginal arteries of Drummond. Okay, so you have the supramesenteric artery, you have the inframesenteric artery. All of these arteries gives off a small branches known as the marginal arteries, or a full name marginal arteries of Drummond. Okay, these arteries will form the arc of Riolan. Okay, these arteries will form a arc-like structure like that. Okay, known as the arc of Riolan, and then this supplies the intestine part. Okay, a large anastomosis exists between the superior mesenteric artery and the inferior mesenteric artery at the at which part?
Junction of midgut and hindgut.
And where is that junction?
Colon.
Where?
Colon.
Okay, where in the colon?
Transverse colon, 2/3.
At the spinning flexure. Okay, the 2/3 and the 1/3 part. Spinning flexure. Okay, must remember the location. Anastomosis. Remember the rectosigmoid junction and the spinning flexure. The two locations. Okay.
Yeah.
So the anastomosis between the midgut and the hindgut, it happens at the spinning flexure. So in the scenarios where you have to operate on the midgut or on the hindgut, okay, and for that purpose, you're just you're clamping the midgut vessels and the hindgut vessels, right? You have to do that, okay. And so so Stephen will ask you, okay, although the surgeon is is clamping these structures, these arteries, then why not the ischemia is happening? Okay, is it because of the collateral blood supply or the anastomosis between the superior mesenteric artery and the inferior mesenteric artery? Okay, so sometimes the inferior mesenteric artery might be clamped during the abdominal aorta aneurysm repair. Okay, and in that case, the hindgut, it won't develop the ischemia. Why? Because of the superior mesenteric artery. It will supply the hindgut in that scenario. Similarly, when the superior mesenteric artery is blocked or some kind of repair is there, then inferior mesenteric artery will supply the foregut structures. And because of these two things, you will never develop the ischemia in the intestine, right? Only when the superior mesenteric artery and the inferior mesenteric artery get blocked, okay, then only in that case you will have a ischemia to the foregut and the midgut. Okay, for the rectum, we have discussed you have the branch of the inferior mesenteric artery. Okay, and this anastomosis will be happen at the rectosigmoid junction. Okay, very important. And yeah, that would be it. Between a superior rectal artery and a branch of inferior mesenteric artery, this anastomosis happened. Okay, so any doubts so far?
No, thank you.
Okay, now you need to know about the portosystemic anastomosis. Very important. Okay. Okay. From your intestine, okay, the veins will drain the blood. Okay. And in most of the parts, okay, when drain the blood, they will ultimately drain the blood into the portal circulation, into the portal veins. These portal veins will carry the blood to the liver. Okay, where the detoxification of the blood will happen. The blood will go to the central vein. Okay, while passing through the zone 3, zone 2, and zone 1, right? From the central vein, the hepatic vein arises, and that will drain the blood into the inferior vena cava. Okay, so as you can see, you have the stomach, you have the spleen, you have the colon, okay, you have the umbilicus, you have the anus. Okay, from these locations, you can drain the blood into the portal circulation. Okay, so from the stomach, you have the left gastric vein. Okay, and this left gastric vein will be directly would drain the blood into the portal circulation. Okay, then you have a superior mesenteric vein, and the superior mesenteric vein will be directly forming the portal vein. Okay, as you can see here, right? This inferior mesenteric vein, okay, which are draining the blood from the hindgut. Okay, it will first drain the blood into the splenic vein, and then this splenic vein will drain the blood into the portal vein. It is very important. Okay, superior mesenteric vein, which means the structures of this midgut, they will directly drain the blood into the portal circulation, into the portal vein. But the structures from the inferior, from the hindgut, which are, which is being drained by the inferior mesenteric vein. Okay, this inferior mesenteric vein will drain the blood first into the splenic vein, and then from the splenic vein, the blood will go to the portal circulation. So in a scenario where you have a blockage in the splenic vein, okay, you will have the edema or the venous congestion in the hindgut as well as in the spleen. Okay, very important. And then this fundus, okay, which is being drained by the short gastric veins. Okay, they will ultimately drain the blood into the splenic vein, just like the artery. The short gastric arteries are originating from the splenic artery. Similarly, the short gastric veins are draining the blood into the splenic vein, which are finally going to the portal circulation, then to the liver. Okay. Blood from the umbilicus can also go to the portal circulation, as you can see here. Blood from the esophagus can also go to the portal circulation, as you can see here. Blood from the anus, from the anal area, as you can see, okay, it is being drained by the inferior mesenteric artery, which is going to the splenic vein, then to the portal circulation, as you can see. So anastomosis can happen at the anal region, at the umbilical region, and at the esophageal region, because from these regions, the blood can be directly drained into the inferior vena cava also, bypassing the portal circulation. Okay. From the anal area, it would be the middle, as you can see, this is the middle rectal vein and the inferior rectal vein. Just like the arteries, the middle rectal artery and the inferior rectal arteries are the branch of internal iliac artery, right? Similarly, the middle rectal vein and the inferior rectal vein, they will drain the blood into the internal iliac vein, right? And they will be in the anastomosis with the superior rectal vein, which is a branch of inferior mesenteric vein. Sorry, would drain the blood into the inferior mesenteric vein, right? So anastomosis will be happen here. So whenever a portal hypertension occur or a blockage anywhere along this pathway occur, you can have a drainage of the blood in the opposite direction. Okay, from the portal circulation to these vessels and then into the inferior vena cava, right? So you can have a anorectal varices because of that. Anastomosis between the superior rectal and the middle and inferior rectal veins, it can lead to the anorectal varices. Similarly, for the umbilicus, you have the paraumbilical veins, okay, and you have a epigastric veins, okay. Just like the epigastric artery, okay, the epigastric vein will be draining the blood into the external iliac artery and then to the inferior vena cava, right? Anastomosis happened at the umbilicus, okay, and yeah, so in scenarios where you have a portal hypertension or any blockage, okay, the blood will be draining from the paraumbilical vein to the epigastric veins, and as a result, you can have a caput medusae, okay. Then for the esophagus, you have the esophageal veins, okay, as you can see here, and you have a left gastric vein. The left gastric vein will be draining the blood from the lower esophagus, okay, and this part is also supplying by the this part is also being drained by the esophageal vein, which is ultimately draining the blood into the azygous vein and then to the inferior vena cava. So in a scenarios where you have a portal hypertension or any kind of blockage, you can have a esophageal varices, right? And because of these esophageal varices, you can have a bleeding complications. A life-threatening bleeding can happen in the esophagus, right? You can even see the dilated or the tortuous veins when you do the endoscopy of the esophagus, okay? And it is because of the left gastric vein and the esophageal veins, okay? So yeah, that would be it. Any doubts so far?
No, thank you.
I'm sorry. Can you explain, like, when Bud Chiari happens, like, what is being affected? Because you
See, in
have like
case of
affective
yeah.
blow, like the.
See, in case of Budd-Chiari syndrome, you're actually blocking the hepatic vein, right?
Mhm.
In that scenario, you will have the the pooling of the blood into the portal circulation, right? You will have the splenic congestion because of this pressure overload and the volume overload thing. Okay.
Okay.
You will have the splenic congestion. You will also have the liver congestion, right? Hepatic congestion. Okay. All of the blood, because it cannot be drained by the by the hepatic veins, now they are being drained by these vessels, okay, from the anastomotic regions, from the anal area, right? From the esophagus, from the umbilicus. So you will get the
Okay.
hemorrhoids, you will get the anorectal varices, you will get the corpus medusae, you will get the esophageal varices along with the hepatosplenomegaly. Okay, and this is for the Budd-Chiari syndrome.
So so I will get kaput medusa as a result of Budd-Chiari syndrome then.
Yes.
Okay.
And any area, in any condition where you're having a blockage in the drainage of the vein from the portal circulation, right? It can happen.
Okay. Okay.
Yes.
Yeah, that works. Thank you.
Okay, thank you. And these three things more. The right colic, because the ascending colon, this ascending colon is on the right side. Okay, so the right colic artery is on the right side. Similarly, the right colic vein is also on the right side. Okay, the middle colic vein and the middle colic arteries are for the transverse colon. Okay, and the left colic artery and left colic vein are for the descending colon and the sigmoid colon. Okay, the ileocolic vessels are for the ileum and the cecum. Now, can anyone tell me the right colic artery is a branch of which artery? Superior mesenteric or the inferior mesenteric?
Superior.
Yes. And the middle colic artery?
Superior.
Again, superior. And the left colic artery?
Inferior.
Similarly, the right colic artery and the middle colic artery, they will be draining blood into the superior mesenteric vein. The left colic artery, the left colic vein will be draining the blood into the inferior mesenteric vein. The ileocolic, which is the artery supplying the cecum and the ileum, and the vein draining the cecum and the ileum. Similarly, they will drain the blood into the superior mesenteric vein. I don't remember the exact question, but I've encountered a very weird question over these three, four facts. Okay, so you must remember the location of the arteries, and ultimately all these colic arteries, they will be giving the marginal arteries of the dromod. Okay, and then this anastomosis happen between the arteries, and then they will supply the these structures. Okay, so that's how this organization of this artery works in the intestine. Okay. First the major vessels, then the colic vessels, then the marginal arteries, then the anastomosis, then some small arteries supplying the small areas. We have discussed the site of anastomosis, the clinical signs, and the polysystemic shunts which are happening, right? Okay, so what is the treatment of the portal hypertension? If you're having any blockage in the draining the blood, you can make a shunt. Okay, where you just bypass these areas. Okay, you will form a portosystemic shunt where you're directly connecting the portal circulation with the venous, the inferior vena cava directly, bypassing the liver. Okay, now all this blood, because if there's a blockage in the liver happen, okay, you need to make a shunt so that the blood can directly go from this portal circulation into the inferior vena cava, bypassing the liver. And as you can see, all this blood was going to the liver because of the detoxification, right? Now, because of the shunt formation, the detoxification will not happen, and the clearance of the ammonia will be decreased. Okay, so portosystemic shunt, okay, or I must say the transjugular intrahepatic portosystemic shunt, okay, it can cause the decreased clearance of the ammonia. Okay, so it is a cause of the hyperammonia also. So although you're preventing the condition of the patient with the portal hypertension, okay, you're also making him prone to develop the hyperammonia, right? Because all of this blood is directly pouring, it is directly would drain the blood into the inferior vena cava, bypassing the liver. So detoxification won't happen. Yes. Okay, is that okay?
Yeah.
Sorry, one question. So you would you not be able to filter at all, or would you still have like a little bit of blood flow, but it's just keeping you from blocking up the blood in your liver via the tips?
Okay, in case of tips, see, it depends on the location. If you're,
Okay.
if you're totally bypassing the liver, then of course 0% of ammonia will be filtered, right? So all of the ammonia will be in the blood, bypassing the liver. Okay. If at some areas in the liver you are doing the shunt, then some ammonia could be cleared, some ammonia will be remain. So it totally depends. okay, how much shunt you're performing, where a shunt is located, right?
Okay. So it can be
But
intra
most-
or
yeah.
extra hepatic shunt.
But most of the time, the shunt will be a complete type. Okay, there will be a complete decrease of the clearance of the ammonia. Okay, and it can precipitate the hepatic encephalopathy, just like written.
All right. Thank you
Okay.
so much.
It depends completely, but okay. Then the anal canal. Okay, and this is a pectinate line you can see. Okay, below the pectinate line, different vessels, different nerve supply. Above the pectinate level, of course, different blood vessels, different supplies, right? Okay. So above the pectinate line, okay, in the upper 1/3, you will have what? You will have the superior rectal arteries, which are the branch of inferior mesenteric artery. Okay. For the middle rectal, for the middle part of the anal canal, okay, just above the pectinate line, you will have the middle rectal arteries, which are the branch of internal iliac artery. And below the pectinate line, okay, you will have the inferior rectal arteries, which are also the branch of internal iliac artery. Okay, so the middle rectal artery and the inferior rectal arteries, these are the branch of internal iliac artery. The superior rectal arteries are the branch of inferior mesenteric artery, right? For the nerves above the pectinate line, okay, it is the visceral innervation, or must say the inferior hypogastric plexus is there. Okay, and does anyone know whether this inferior hypogastric plexus is a sympathetic plexus or the parasympathetic plexus?
Parasympathetic.
Good. Okay. Yes. Just give me a second, guys. Yeah, this is the confusion part. See, this inferior hypogastric plexus is not the parasympathetic plexus, but the sympathetic plexus. Okay, the splanchnic plexus, the pelvic splanchnic nerves, these are the parasympathetic ones. Okay, the inferior hypogastric one are the sympathetic nerves. Okay, do not get confused between them. Okay,
Okay,
is that
thank
clear?
you.
Inferior
Yeah.
hypogastric plexus is the sympathetic plexus, and the pelvic splanchnic plexus is the parasympathetic plexus. Okay, this was a huge confusion during my preparation, so please make sure you don't confuse between the two. The name is kind of very much similar. Okay, but yeah, this is a sympathetic one. The arteries, the superior branch of the inferior mesenteric artery, is supplying the upper 1/3 of the anal canal. For the veins, you have the similar superior rectal vein supplying into the inferior mesenteric vein, then to the splenic vein, and then to the portal veins. Okay. For the lymphatics, we have discussed the lymphatics from the anal canal. Remember, below the pectinate line, you will have drainage to which lymph nodes? Superficial inguinal, right? Above the pectinate line, you will have the internal iliac lymph nodes. Okay. Then below the pectinate line, you will have the somatic innervation. Okay, not the visceral, but the somatic innervation, which is by the pudendal nerve. Okay, supplied by the roots S2, S3, and S4. For the artery, it would be the inferior rectal artery, vein, inferior rectal vein. Okay, and the lymph nodes will be the inguinal lymph nodes, superficial inguinal lymph nodes. Okay, and as you can see, the blood below the pectinate line will be directly, will be directly draining into the inferior vena cava, and the blood in the anal canal above the pectinate line will be draining into the inferior mesenteric vein. So whenever a portal hypertension occur, all of the blood will be which is in the superior rectal vein, okay, will be started draining by the this middle rectal vein and the inferior rectal vein, and that can lead to the anorectal varices also. Okay. So any doubts so far about the nerves, arteries, veins, and lymphatics?
I have one question.
Yes.
Since the inferior hypogastric plexus is giving supply to the area above the pectinate line, it means that
Yes.
the inferior hypogastric plexus is forming from the nerves which are coming from L1 and L2, right?
Yes, exactly.
Okay, got it. Thank you.
Okay. So above the pectinate line, you will have the internal hemorrhoids. Okay, and because all of the cells are columnar cells here, so they will be lined by the columnar epithelium. Okay, and internal hemorrhoids, they receive the visceral innervation, and that's why they are not painful. They are not painful, very important, right? Now, below the pectinate line, the innervation is a somatic innervation, right? And whenever external hemorrhoids occur, they are always very much painful because of this somatic innervation. Okay. Above the pectinate line, you will get the adenocarcinoma because of the columnar epithelium. Below the pectinate line, you will have the stratified squamous epithelium, right? Non-keratinized type. That's why you will have a squamous cell carcinoma. So squamous cell carcinoma below the pectinate line, adenocarcinoma above the pectinate line. You will also have a anal fissures below the pectinate line, not above the pectinate line. Okay, and these all conditions are very much painful. Okay, because of the somatic innervation. Okay, so yeah, let's talk about the anal fissures. Okay, compared to the anterior wall or the anterior part of the anal canal, the posterior part is kind of devoid of veins and the arteries. You don't have much veins and much arteries in the posterior region than the anterior region, right? So in a scenario where where the patient is kind of very much straining or increasing the pressure for the blood supply, okay, the posterior part will become ischemic first. Okay, think like a watershed area, right? So posterior part will be damaged first, and so that the anal fissures are mostly happen in the posterior location. Okay, because this posterior location is very poorly perfused. Okay, why this happened? Because of the stretching, because of the straining. Okay, generally seen in the old age patients or the patient with a history of constipation. Okay, they need to strain more, they need to increase more pressure. Okay, and that's why it can lead to the longitudinal tears. Very important, there will be the longitudinal tears happen most commonly in the posterior location. Why? Because posterior location is very poorly perfused. How the patient will present you? It will present with a very painful pooping. Okay, a very pain while the defecation. Okay, also the patient will get the blood on the toilet paper. Okay, so pain, blood. Okay, posterior location. Okay, and yeah, cause will be the stretching or the straining and the constipation. That's all about the anal fissure. So whenever you encounter a patient having a very painful defecation, okay, and as soon as the stool passes, the pain is resolved. Okay, but the patient get a blood on the toilet paper, okay, or on the stools. Okay, that's how you know that this could be a case of the anal fissures. Apart from this, on the examination, you will get to see the longitudinal tears on the anal canal. Okay, making 100% sure case of the anal fissures. Is that okay?
Yeah, I have one question.
Yes.
Below the pectinate line, the epithelium is having the epithelium is keratinized or non-keratinized?
Non-keratinized.
Because below the pectinate line, it should be skin. So so should it not be keratinized?
Oh, sorry. The keratinized non-stratified, I think it was. This. Well, let me confirm that again. Just give me a second. I'm
Yeah,
confusing it here.
And regarding inferior hypogastric plexus, like
Yeah.
it is said like it is ANS parasympathetic plus sympathetic. It receives innervation.
Please repeat it again.
So like I think I wrote it from the UWorld only, and I'm checking it on Emboss. So it sees for inferior hypogastric plexus and autonomic nerve plexus located on the lateral pelvic wall.
Yes.
Further, it is written receives sympathetic fibers from the superior hypogastric plexus.
Yes.
It also receives parasympathetic fibers from the pelvic splanchnic nerves.
Yeah, pelvic splanchnic nerves for the parasympathetic and the hypogastric plexus for the sympathetic. That's what I said, I think, right?
Okay.
Okay.
I heard it like maybe wrong. I heard it. Okay. Yeah. Thank you. Thank you so much.
Okay. Yeah. So it was non-keratinized, not keratinized. Okay. Non-keratinized stratified squamous epithelium.
Okay, okay. Thank you.
Okay. Not the keratinized.
Okay.
And that's why, we have discussed that about the human papilloma virus, that it only affects the squamous epithelium, right?
Yeah, yeah.
So that's why the squamous cell carcinomas only happen after the pacnate line, and they're always caused by the human papilloma virus, right? And
Yes.
adenocarcinomas can happen before the pacnate line, can be caused by any other causes. Okay.
Yeah, yeah. Okay.
Second
Thank
cause,
you.
the second thing will be the hemorrhoids. Okay. For the hemorrhoids, you will get the similar presentation just like the anal fissures. The patient will have a pain while pooping. Rectal bleeding would be there. Will present as a blood on the toilet paper. Important thing will be the itching. Okay, a continuous itching. Okay, in the anal area. Patient will also have a swelling mass. Instead of the tears, okay, instead of the fissures on the examination, what you will see is the swelling. Okay, and the risk factors, they include the obesity, pregnancy, constipation, straining while defecating. Okay, these are the risk factors for the hemorrhoids. Okay, and yeah, that's all about the hemorrhoid. Yeah, any doubt?
No, thank you.
Okay, then you also need to know about three sphincters, three things which control certification. One is the internal or inner anal sphincter. Second is the external anal sphincter, and third is the puborectalis muscle. See, because all of the area after the pacnate line is supplied by the somatic innervation, which is under your control, right? So this external anal sphincter is voluntary, internal anal sphincter is involuntary. Okay. So for the defecation, both these sphincters must be relaxed. Okay, and the puborectal muscles must be contract. Only then the defecation can happen. Okay, whenever the whenever this internal anal sphincter is relaxed, okay, the patient will get the urge to defecate. Okay, and then it depends on the patient. If they relax the external anal sphincter, defecation will occur. If they do not relax the external anal sphincter, defecation won't occur. Okay, desired defecation, you can say. Then you also have the abdominal muscles, okay, which increase the pressure gradient of the rectum so that expulsion of the feces can happen. Okay, so four things. One, internal anal sphincter. Second is the external anal sphincter. Third is the puborectal muscles, and fourth are the abdominal muscles. These three muscles are must, but the abdominal muscles, they are kind of doing more their job, something like that. Okay, above them, above these three muscles, okay, abdominal muscles will help. They will increase the pressure, causing the rapid expulsion of the feces. Okay, so the constipation occurs whenever either of these two sphincters fail to relax or the puborectalis muscles fails to relax. Okay, because these are areas, because this is a muscle which is forming the external anal sphincter. Okay, so the constipation will occur whenever the puborectal muscle, okay, which is a part of your external anal sphincter, it is failed to relax, okay, which is supplied by the pudendal nerve. Okay, so in any case where you have a paralysis, okay, where you have a nerve damage, like say, right, where you have a pudendal nerve damage, okay, in that case you cannot relax the puborectal muscles. As a result, the anal sphincter won't be open, and as a result, the patient can get the constipation. Okay, it is most commonly occurs in the elderly and the neurological disorders like the multiple sclerosis, the Parkinson's, or any kind of trauma. Okay, like during the child delivery, okay, some tears can happen which can reach to the pudendal nerve. Damage can happen into that area, and that can lead to the constipation. Okay, that would be all. Any doubts so far?
No, thank you.
Okay, then you need to know about the liver. Okay, these liver, the liver completely is made up of these hexagonal structures. Okay, this liver is made up of the hexagonal structures, and these are known as the hepatic lobules. Okay, these are the hepatic lobules, which are the functional unit of the liver. Multiple hepatic nodules, they will form the lobes. Okay, finally the lobes will form the liver completely. Okay, so these are the functional unit of the liver, these hepatic lobules. Okay, at the edge of the hepatic lobules, you have the portal triad, which consists of a portal vein, hepatic artery, and the bile duct. Okay, in the central of every hepatic lobule, you have a central vein. Okay, the blood flow, the oxygenated blood flow will happen from periphery to the center. And so now you can see that it's zone 3, because this hepatic lobule is divided into 3 zones. The zone 3, which is the innermost zone, the zone 2, which is the middle zone, and the zone 3, which is at the periphery. Because the blood supply will be happening from periphery to the center, this zone 3 is the watershed zone in the hepatic lobule. Okay, very important. When you look for the hepatic nodule, you have the hepatocytes. All of these are the hepatocytes. Okay. On the basal side of the hepatocytes, okay, you have the venous sinusoids. As you can see, these are the sinusoids where the blood is present at the basal part. This is the apical part. This is the basal part. Okay, at the basal part, you will have this. Just give me a second. Yeah, at the basal part, you have the sinusoids. Okay, and if this is the basal part, then this must be the apical part, right? If I zoom in the diagram, this is the basal part. Okay, and the basal part is in contact with the sinusoids. Okay, and the apical, if this is the basal part, then the apical part must be in the contact with the bile ducts. Okay, so this is the periphery part. Okay, and like we have discussed, the blood supply will be happening from periphery to the central, towards the central vein. Okay, the blood supply will be happen with the help of sinusoids, which are lined by the endothelial cells, as you can see here. Okay, within the blood, you will have the macrophages, as you can see. You will also have the Kupffer cells, okay, which are present in the sinusoids, killing the microbes. Okay, the blood flow will be happening from from the periphery to the center in this direction. Okay, and the formation of bile, or the flow of bile, I must say, it will be happening from center to the periphery. Flow of bile from center to the periphery, flow of blood from periphery to the center. Okay, the bile will be in the will be in the apical surface. Okay, and the blood or the sinusoid will be in the basal surface. Okay, so this is the kind of the anatomy of your hepatic lobule. Okay, any doubts so far in this?
No, thank you.
Okay. Then you also need to know about, forgot to mention. See, this is your hepatocytes, and this is your sinusoids. In between the blood sinusoids and the hepatocytes, you have some interstitial space. This is a yellowish part, which you can see. This is the interstitial space, and this interstitial space, it contains the stellate cells. Okay, it contains the stellate cells, also known as the ITO cells. ITO. Okay, the function of these cells is to normally store the vitamin A. Okay, the function of these cells is to store the vitamin A whenever they are inactive. Okay, but once some kind of injury happened to the liver, okay, then during the wound healing process, these cells can get activated. Okay, and when the cells get activated, they can cause the fibrosis. Very important. Okay, so hepatic stellate cells, or the ITO cells, okay, whenever they are inactivated, they will store the vitamin A. But whenever an injury happens, okay, and they get activated, they will transform into the myofibroblast. They will cause deposition of the collagen. Okay, and along with the deposition of the collagen, they can cause the fibrosis. Okay, very important. So these are the cells which are responsible for the hepatic fibrosis or the cirrhosis. So whenever a step one asks you why the patient is having a cirrhosis, it is because of the activation of the ITO cells or the hepatic stellate cells. Okay, then let's talk about these 3 zones. The zone 1, which is the periphery. Okay, it is first affected by the viral hepatitis. And does anyone know why this zone first affected by the viral hepatitis?
Maximum viral load,
Why is that case?
because it's coming to the lobule via the hepatic artery and hepatic
Yeah.
artery.
Yeah, exactly, because of the hepatic artery. Okay, and that's why in case of in case of a hepatitis A, because it is a GI, because hepatitis A is of the fecal route, right? So the hepatitis A will be transferred by the portal vein. Okay, and the flow of the portal vein is again from the periphery to the centers. So the cells which are at the periphery, they will be in the first contact with the virus, then the zone 3 cells, and so these cells, the cells in the zone 1, they will be most commonly affected by the hepatitis virus. Okay, in case of hepatitis A, so it would be the portal vein. In case of hepatitis B, it could be the hepatic artery. Okay, very important to note. These areas are best oxygenated, which makes sense because they are at the periphery near the blood vessels, right? Ingested toxins, okay, they will always, like the cocaine, they will always first affect the zone 1 or the peripheral zone. Then comes the zone 2, which is for the yellow fever, very important. The yellow fever virus most commonly affects the zone 2. Does anyone remember what category of this virus is, the yellow virus?
Flavi?
Flaviviridae.
Yeah, exactly. Flavivirus. Okay, flavivirus will be the yellow ones. And does anyone remember what disease this yellow fever can cause?
Hepatitis.
A kind of hepatitis, and any other specific thing along with the hepatitis?
Jaundice.
Yeah, jaundice will happen because of the hepatitis, of course.
Is it a hemorrhagic fever?
Not the hemorrhagic fever, but yeah, hemorrhage can happen in the GI tract, and that can lead to the black vomitus.
Okay.
Okay, very important thing for the yellow fever. It will affect your liver. It will cause a hepatitis. It will cause a hepatomegaly, high ALT/AST count. Okay, it will cause a jaundice, of course. Okay, then after that, it can also cause the GI bleeding, right? And because of that, you can have a very bleeding vomitus, or Stephen can describe this as a black vomitus or a brown vomitus, the coffee ground emesis. It can happen with the yellow fever. And they can ask you which zone this yellow fever affects. It would be the zone 2. Zone 3, the watershed zone, it is least oxygenated, affected first by the ischemia. Highest concentration of cytochrome P450 is present. And because the highest concentration of cytochrome P450 is present here, most of the metabolism of the toxins will happen here. Okay. When you ingest too much of the acetaminophen, you will have a damage to the liver. And does anyone know how?
NAPQI synthesis.
Yeah. And what does it can lead to?
Sorry.
What does NAPQI lead to? How does NAPQI causes the liver damage?
Decreases the glutathione stores.
Yeah, so oxidative damage will occur, and first it will occur in the central zone, near a central zone, or the zone 3, because highest concentration of P450 is present, and this P450 is responsible for the activation or the conversion of the acetaminophen to the toxic metabolite, right? Similar thing goes for a carbon tetrachloride, for the ethanol, for the halothane, for the rifampin. Okay, so metabolism of toxins will be happen in the zone 3 mostly. The site of alcoholic hepatitis is also the zone 3 mostly. Okay, very important. Know these locations of different diseases. Okay, very important to know the function of Kupffer cells. Okay, know where the sinusoids are present on the basal surface. Know where the bile ducts are present at the apical surface. Okay, know the flow of blood which is from the periphery to the center. Know the flow of bile which is from the center to the periphery. Okay, which cells can cause a fibrosis, hepatic cell I2. Normally they store the vitamin A. Okay, and yeah, that would be all about the liver architecture. As you can see, this is the hepatic artery. These are the bile ducts, and these are the portal vein. Okay, and this is at the periphery. From there, your hepatic lobules will start. Okay, very important. And these are the hepatic sinusoids, as you can see here. This is a complete hepatic sinusoid. Lining the sinusoids will be your ito cells. Okay, these are the ito cells lining the hepatic sinusoids. Okay, very important. Yeah. And these are the Kupffer cells which are located in the this. Located in the these sinusoids. It's okay. So this is the hepatic sinusoid complete. Yeah. So any doubt on this page?
Why do you have hepatitis A from the veins, but hepatitis B from the hepatic artery?
What is the route of transmission of hepatitis A?
Hepatitis A is ingested fecal oral, so it's coming in from your
Intestine. And where does from the intestine it go?
intestine into the oh, so it would
Portals.
be like the veins, the
Portal veins, right?
Okay.
So that's why it will reach to the liver first. It will cause hepatitis. For the
Mhm.
hepatitis B virus, it is the parenteral route, right? The blood route. So it will go to the liver by the hepatic artery. Okay.
Okay. Yeah, that works. Thank you.
Okay, now comes the biliary structure. Okay, so you have two lobes of the liver. Okay, the right lobe and the left lobe. Okay, right lobe and the left lobe, they will form some ducts for the bile. Okay, the right duct and the left duct, they will join to form a common hepatic duct. Okay, so you have a left hepatic duct, you will have a right hepatic duct. Both of these ducts will join to form a common hepatic duct. Okay, there is a gallbladder. Okay, from the gallbladder there will be a cystic duct. Okay, so whenever you heard the word cystic, okay, it is always referring to the gallbladder, the cystic artery. Okay, the cystic duct, cystitis, it is always for the gallbladder. So cystic duct originates from the gallbladder. It will join the common hepatic duct. After joining the common hepatic duct, it will form the common bile duct. This is the common bile duct. Okay, reaching to the pancreas, it will join the main pancreatic duct. Okay, after joining the main pancreatic duct, okay, they will open at the ampulla of the Vater, okay, which is guarded by the sphincter of Oddi, okay, and the ampulla of the Vater, okay, which is present. Okay, just know which structures open here. It would be the common bile duct and the main pancreatic duct. You also have a accessory pancreatic duct. Opening of the accessory pancreatic duct is present here. Okay, which is for the minor papilla, and this is the major papilla in the duodenum. Okay, so minor papilla for the accessory pancreatic duct opening, and the major papilla is for the this ampulla of Vater opening. Okay, so just give me a second again. So whenever a gallstone happens, okay, this gallstone can enter a cystic duct. From cystic duct, it can block directly the ampulla of Vater. And if it blocks the ampulla of Vater, now before the obstruction, inflammation can happen because of raised in the pressure. The blood supply could be compromised, bacteria will be overgrown, and that can lead to the pancreatitis, which is before the blockage. It can lead to the cystitis, okay, and the cholangitis, I must say, because of the stones. Okay, so whenever you have a gallstone, it can lead to both the cholangitis, okay, and as well as the pancreatitis. Very important. When does it happen? Whenever the stones blocks the ampulla of Vater. Okay, very important. And whenever a tumor is arised from the head of the pancreas, as you can see, it is very much in a very close association with the ampulla of Vater. Okay, so whenever a tumor happens, it can block the ampulla of Vater, right? So it can cause the enlarged gallbladder, and this is a very characteristic sign for the pancreatic cancer. Okay, whenever you encounter a patient with the pancreatic cancer, they will always present you with a history of very painless jaundice and a enlarged gallbladder. So whenever you encounter a patient having a very enlarged gallbladder and a painless jaundice, the first thing that must come in your that must come into your mind would be the pancreatic cancer. Okay, head of pancreas. Okay, very important. And yeah, that would be all about the biliary structures. Okay, the right hepatic duct, left hepatic duct join to form a common hepatic duct. It will join the cystic duct to form the common bile duct. It will join the pancreatic duct to form the ampulla of Vater and the sphincter of Oddi. If a blockage happen here, it can lead to the cholangitis and the pancreatitis. If a cancer happen at the head of pancreas, it can block the ampulla of Vater. It can cause the painless jaundice with enlarged gallbladder. Okay, any doubt?
No, thank you.
Okay, then comes the femoral regions. Okay, on the very median, you have the lymphatics. Okay, just lateral to the lymphatics, you will have the veins, the femoral vein. Then you have a femoral artery. And does anyone know this femoral artery is a continuation of which artery?
External iliac.
Exactly, external iliac. And as soon as this external iliac gives off a branch, which is, anyone know the last branch of external iliac?
Epigastric, inferior epigastric.
Not the inferior epigastric.
Deep circumflex.
Exactly, deep circumflex artery. As soon as the external iliac artery gives a branch, which is the deep circumflex iliac artery, it will become the femoral artery. Okay. And then the femoral artery will enter something known as the this femoral canal. Okay, very important, the femoral canal. And the nerve is the most lateral structure that enters the thigh. Okay, femoral region. Nerve is the most lateral structure, and this nerve is not a part of this canal. Very important. Nerve is not the part of the femoral canal. Okay, or the femoral sheath, I must say. Okay, and yeah. So going from lateral to medial, you will encounter the nerve, then artery, then vein, and finally the lymphatics. Okay, femoral triangle, which contains the nerve, artery, and the vein. This is a femoral triangle, as you can see. It will contain the nerves, it will contain the artery, it will contain the vein. Okay, if step one asks you about the boundaries, so on the medial side, you will have the adductor longus muscle. Okay, for the lateral, you will have the sartorius muscle. For the base, you will have the inguinal ligament. Okay, very important. Femoral sheath, which is formed after the inguinal ligament. Okay, it contains the vein, it contains the artery, it contains the lymph nodes, but it do not contain the femoral nerve. Very important. Okay, and this is where the the saphenous veins. Okay, they will drain the blood into the femoral vein at this part only. Okay, so in a scenario where you have to take the graft for the patient and you are taking the graft from the saphenous vein, so step one can ask you where should you use the graft. Okay, very important. Step one will ask you this case, if you want to take a graft from the saphenous vein, then where should you make the incision or where should you take the graft? Okay, so it will be in the femoral location. It will be from the femoral triangle, because this is the location where the saphenous vein drains the blood into the femoral vein. Okay, and you can easily access the vein here, right? Just lateral to the lymph nodes. Okay, the femoral lymph nodes. Very important. And veins are also the site for the catheter placement, right? For the femoral catheter placement, you will use the veins. Okay, and for that you first need to palpate the artery. You first need to palpate the femoral artery, and shortly medial to the femoral artery, just after just medial to the femoral artery, you need to put your catheter. Okay, so step one can ask you this thing also. So basically they will check you if you know the if you know that the artery is kind of lateral, vein is medial, and lymphatics are most medial, and nerves are most lateral, right? So they can ask you about the catheter placement. They can ask you about this the graft location. Okay, they can ask you about the lymphadenopathy. Okay, if the lymphadenopathy occur in the femoral region, it would be most probably medial to the vein, of course. Okay, so just need to know from lateral to medial what structures come. Okay, and yeah, that would be all about this. Any doubt?
No, thank you.
Then let's discuss about the inguinal canal. Okay. So first you have the parallel peritoneum, okay, which is covering your organs, of course, right? And just behind the parallel peritoneum, you will have the which sac?
Greater sac.
Greater sac. So whenever you cut all of these layers, you can directly enter into the abdomen via greater sac. And then you can easily visualize these liver, the stomach, and all of these structures. Okay. Only when you enter into the parietal peritoneum and the visceral peritoneum, only when you remove these structures, you can easily visualize the organs. Okay. So now let's come back to the inguinal canal. So you have the parietal peritoneum. Okay. Just anterior to it or superficial to it, you will have the extraperitoneal tissue. Okay. Then you have a fascia of the muscle, which is known as the transversalis fascia. Okay. After the transversalis fascia, on the medial side, okay, in the very midline, you will have the rectus abdominis muscle. Okay. You will also have a set of muscles which are known as the transverse abdominis muscles. Anterior to the transverse abdominis muscle, you will have the internal oblique muscles, which are the abdominal muscles, of course. Okay. The transverse abdominis muscles and the internal oblique muscles, they will join to form the conjoint tendon. Okay. And then on the outermost side, you will have the external oblique muscle and the aponeurosis of the external oblique muscle. So first is the peritoneum, then the fat, then the transversalis fascia. Okay. On the middle side, you will have the this rectus abdominis muscles. Okay. Then you have the transversalis muscle. Okay. Then the external oblique, sorry, then the internal oblique, and finally the external oblique. The internal oblique and the transversalis muscle, they will join to form the conjoint tendon in the midline, as you can see in the middle side. Okay. And these are your inferior epigastric vessels, which we have studied. These are the branches of your external iliac artery. Okay. And they will supply the anterior abdominal wall completely. This is the midline. This is the anterior abdominal wall. Okay. So for the inguinal canal, okay, you have this, you have the involvement of the transversalis fascia, as you can see. First, you will have the deep this inguinal ring, also known as the internal inguinal ring. Okay, you have the deep inguinal ring. From the deep inguinal ring, okay, the inguinal canal will pass through the this transverse abdominal muscle, but it won't penetrate the muscle. Okay, the muscle has a shape. It will, this muscle will form a tunnel over this inguinal canal. So inguinal canal don't need to pierce the muscle. Okay, it will pierce the this internal oblique and then the external oblique. Okay, and finally reaches to your scrotums completely. Okay. So initially, because you know that during the developmental time, during the embryological time, the scrotums were in the abdomen, right? And they need to, get into the these sacs, right? The scrotal sacs. Okay, and this is the path that scrotums always take to reach to the scrotal sac. First, they need to pass through the internal inguinal ring. Okay, then they need to pierce the internal oblique muscle, then the external oblique muscle and the aponeurosis of it. Okay, and finally it can reach to the this scrotal sac. Okay, so step one can ask you all the layers of the inguinal ligament, the layers of the inguinal canal. Okay, from the innermost, you will have that internal spermatic fascia, which is made up of the innermost layer, which is the transversalis fascia. Okay, the middle structure is the cremasteric muscle. Okay, which is formed by the internal oblique, the middle layer, internal oblique muscle, cremasteric muscles. And then you have the external layer, which is formed by the external oblique muscles of the external spermatic fascia. So external spermatic fascia, okay, then the cremasteric fascia, and finally the internal spermatic fascia. So in between two spermatic fascia, you have a cremasteric fascia. Okay, the external one is formed by the external oblique, middle one the internal oblique, and the innermost layer is the transversalis. Okay, and these muscles, the cremasteric muscles. Okay, due to which you can have a cremasteric reflex. And does anyone remember the nerve name which takes part in the cremasteric reflex? nerve name which takes part in the cremastic reflex?
Pudendal.
Uh, Not the pudendal. No.
Ilioinguinal.
Which one?
Ilioinguinal nerve.
No. Try again.
Iliohypogastric.
No.
Genitofemoral.
Exactly. Genitofemoral nerve, right? So as the name suggests, the genito and the femoral, this is a nerve will supplies your genitals as well as the femoral region. And that's why whenever you touch something on the thighs, on the middle side, you will have the cremastic reflex, right? Because this nerve is supplying both your the middle side of the thigh and as well as the genitals. That's why the name genitofemoral. Okay. You can easily remember the function by the name. Is that okay?
Yeah.
Okay. So this inguinal canal is clear to you? Why we need the inguinal canal? Because the scrotum needs to pass, okay, from the abdomen to the scrotal sac, okay, and they will take this path. While passing, it will form a canal-like structure, a tube-like structure where all these, um, uh, the vas deferens and other structures passes through these canals only, the inguinal canal, okay, and then to the abdomen. Okay, so that's why this inguinal canal is important. You need to know the layers and the muscles and these layers which are involved in the formation of the inguinal canal. Okay, so yeah, this is the inguinal, the deep inguinal ring, and this is the superficial inguinal ring. The deep inguinal ring in this is the site of the indirect hernia, okay, which is lateral to the epigastric vessels, okay, medial to the epigastric vessels. Whenever the weakness in the abdominal wall occur, this can lead to the direct hernia. So direct hernia is medial to the epigastric vessels, and indirect hernia is lateral to the epigastric vessels. Very important. Same thing, which is lateral diagram. Okay, as you can see, these are your inferior epigastric vessels. Okay, and this is a genital branch of the genital femoral nerve. Okay, very important, as you can see here. Right, this is a iliac and this is a femoral nerve. Okay, this is a pubic tubercle. This is the anterior superior iliac spine. Okay, very important. This is the anterior superior iliac spine. This is a pubic tubercle. Okay, you are having the entry of this external iliac vessels. As you can see, this is the external iliac vessels entering in the thigh, right? Yeah. Good. That would be all for now on this page. Yeah, any doubts so far?
No, thank you.
Okay, now we will discuss the hernias after a short break, okay?
Okay.
So a protrusion of the peritoneum, which is covering your stomach, your intestines, right, your liver and many other organs. Okay, whenever this peritoneum is herniated, and so that the contents of the peritoneum also, the intestinal contents of the stomach or other things, okay, whenever they herniate through an opening, okay, and this opening is usually from a site of weakness, okay, this can lead to the hernia. Okay, sometimes these hernias can be incarcinated, which means they can never be reduced normally. Normally, whenever you press at a hernia, you will see that hernia is reduced, okay, and when the pressure is again increased, the hernia will be again uh, they can come up, right? So sometimes what happens is the incarceration happens, and now the herniation will become not reducible type. Now you need to do the surgery, okay, otherwise you cannot reduce the hernia just like that. Okay, second important thing is the risk of strangulation. Okay, because of the herniation usually form a very small opening, right? So the blood vessels can be compromised, can be compressed. Okay, so strangulations of that hernia can happen, and that can lead to the ischemia and the necrosis. It's a very painful condition usually. Okay, and this makes the herniation very complex. Okay, it will make the herniation very tender. Okay, very erythematous, fever would be there, pain would be there, right? So we will discuss all these scenarios later now. So the first one is the diaphragmatic hernia. For that, you have two type of hernias. Okay, one is the sliding hiatal hernia. Okay, so you can see this. Second is the paraesophageal hernia. So two types of hernia for the diaphragmatic hernia. Okay, one is a sliding hiatal hernia. Okay, and second is the paraesophageal hiatal hernia. Okay, it generally happens because of a defect in the phrenoesophageal. See the name, phrenoesophageal or the pleuroperitoneal membrane, which is the membrane which is covering your esophagus. Okay, and it joins to the diaphragm. And we generally use the word phrenic for the diaphragm, right? So phrenoesophageal membrane and the pleuroperitoneal membrane. Okay, this is a site where the esophagus joins the diaphragm. And does anyone remember the opening of the esophagus in the diaphragm?
T10.
Right? Yes. So it is the location where this membrane is present. Now, whenever a weakness is present in this membrane, okay, which generally happens because of a regular coughing sometimes, or regular straining, right? Or it could be a case of GERD, maybe. In that case, what happens? A weakness of this phrenoesophageal or the pleuroperitoneal, this membrane happens, and as a result, this esophagus will be shifted upwards, or I can say slided upwards, right? And because of that, your sliding hiatal hernia occurs because of a weakness in this membrane, the this phrenoesophageal or the pleuroperitoneal membrane. Okay, so any kind of laxity in the phrenoesophageal or the pleuroperitoneal membrane can lead to the this sliding hiatal hernia. Okay, generally happens because of a regular coughing, regular vomiting. So it could be a case of alcoholics, it could be a case of bulimics, okay, and it could be a case of a chronic coughing patient, right? So this allows the GE junction, which is a gastroesophageal junction, to be shifted upwards, and so that the proximal esophagus with it. And does anyone remember what part of what part of stomach is present here near the this esophagus?
Fundus.
Fundus part is there, not here. This is a cardia part, cardia of stomach. Okay.
Yeah.
So this part will be shifted upwards, and as a result, the lower esophageal sphincter, which is present in this location, right, it will also shift it upwards, right? And as a result, the lower esophageal sphincter tone will be lost, and patient can also get the GERD. So whenever a patient gets a sliding hiatal hernia, okay, he will always get the GERD because of an incompetence in the GE sphincter, because of a shifting of this esophagus and the proximal stomach along with it, right? So a classical symptoms would be the GERD, of course, and because of that, the patient can get the heartburn, epigastric pain, or the chest pain would be there. Okay, a history of regular coughing, or an alcoholic, or any bulimic would be there, right? And not a history of regurgitation is there in the patient. So these is for the sliding hiatal hernia. Second is the and yeah, one more thing, this sliding hiatal hernia is most commonly seen only in the adults, not in the children, not in the newborn, only in the adults. Okay. Now this phrenoesophageal, this paraesophageal hernia, which occurs because of an incomplete formation of membrane. Okay. Whenever a phrenoesophageal membrane is absent at some location, let's suppose this location, okay, then the part of diaphragm is absent in this location. And as a result, because of an opening, the fundus part of the stomach will be herniated upwards into the thorax, right? So because of a defect, it is because of the sliding hiatal hernia is because of the laxity, okay? But the this paraesophageal herniation is because of a defect, a hole in the phrenoesophageal membrane. Now, as a result of a laxity, sometimes it happens because of a laxity in the gastrocolic and the gastrospheric ligament, which makes the stomach very prone to to slide upwards. Okay, and this leads to a gastric fundus being migrate in the thoracic cavity, gastric fundus in the thoracic cavity, and as a result, the lungs will be compromised. the surface area of the lungs will be compromised. The patient will get the respiratory distress. Okay, chest pain will be there. And when you do the X-ray of the patient, you can even see the bubbles of air in the thorax. Okay, and these bubbles must be in the inside the stomach only. Okay, but now you're seeing the gases in the thorax. And when you do the auscultation, you can even see, you can even hear the intestinal sounds in the thorax. So whenever you heard this kind of a scenario where the patient is having the intestinal sounds in the thorax or some kind of a bubbles in the thorax, okay, and a respiratory distress, right, there must be a case of paraesophageal hernia. Now, because of the paraesophageal hernia, this herniation can even compress the esophagus sometimes. Because of this hernia, whenever this part is herniated, this can even compress the esophagus sometimes, and that can lead to the dysphagia and vomiting. Dysphagia can happen to the patient, regurgitation can happen, aspiration can happen, vomiting can happen because of this, right? Very important to note about this paraesophageal hernia. Now, this defect can be present since the birth, okay? So it can also happen in the children, in the infants, in the newborns, right? Very important. It can also happen in the newborns. And whenever it happens to the newborns, because, in during the development of the fetus, okay, because of this herniation, the lungs will not be properly formed, right? And as a result, just after the birth, the baby will present with the this respiratory distress. Okay, you will have an asymmetric aeration. Why? Because the left side of the lungs are being compromised because of the herniation of the stomach, right? So asymmetrical aeration would be there. And remember the scaphoid abdomen. Remember, we have studied this scaphoid abdomen. No one? Anyone can try? Scaphoid abdomen, where we have studied this previously, where you can find a scaphoid abdomen in a patient.
Marfan?
Marfan syndrome.
No, not the Marfan syndrome. In the malnutrition, remember? In the tumor chapters, we have discussed about this, the cytokines which can cause a peripheral muscle wasting. Remember? We've discussed about the scaphoid abdomen there. Whenever you have a malnutrition, okay, you can have a scaphoid abdomen, right?
Yeah.
Okay. So don't forget about this scaphoid abdomen. You can see this in the malnutrition cases. Okay, in case of tumor, right? Where you have a weight loss because of the tumor, it can lead to the scaphoid abdomen, right? And this scaphoid abdomen can also seen along with the diaphragmatic hernia in the child, the congenital diaphragmatic hernia, right? The paraesophageal hernia, right? Now, so these neonates will present you with the respiratory distress. Okay, you will have a asymmetric aeration, scaphoid abdomen. When you do the biopsy, you can even see the bubbles of airs, okay, inside the thorax. So this will be a sign of this herniation. Second thing, you can also on the auscultation can hear the bowel sounds. Okay, bowel sounds would be hearing in the thorax. So you can imagine that there must be a hernia present. Other thing would be the nasogastric tube. When you insert the nasogastric tube in the child, you can even see the nasogastric tube in the thorax. Okay, it will going all the way down here into the stomach, and then it will herniate along with the stomach to the thorax. So when you see the nasogastric tube in the thorax, you can easily imagine that stomach must be present in the thorax, and this must be a case of paraesophageal membrane. It is because of an incomplete membrane formation. Okay, very important. And yeah, and when should you suspect a case of diaphragmatic hernia? because some similar respiratory distress you can even also get along with one condition. And does anyone remember the neonatal respiratory distress syndrome, right? Yeah. So if just respiratory distress is given, no other hints, just we have discussed in this, like the asymmetric aeration, like the scaphoid abdomen, like the bubble sounds or the bubbles. Okay, nothing is given. You're just a patient with a history of like a 39-week gestation. The baby is born with a 39-week gestation, and now he's having a respiratory distress. And you need to choose between the neonatal respiratory distress syndrome and the diaphragmatic hernia. Which option would you choose?
NRDS. Diaphragmatic hernia.
Why not NRDS?
Because NRDS usually occurs if the baby is born premature.
Yes, very important, very, very important. You just need the weak gestations when the baby is born. If the baby is born before 30 weeks, okay, something like that, then there must be a case of NRDS. You cannot suspect the diaphragmatic hernia, even though they are giving you some hints that it could be because they will give you some hints that will make you think that this could be a case of diaphragmatic hernia. But when you look at the gestation age of the baby, okay, which is around 30 weeks, then you immediately know that this must be a case of NRDS, not a diaphragmatic hernia. And when you get a full-term baby, and even after the full-term baby, the baby is having a respiratory distress, okay, then you can immediately know that this must be a case of diaphragmatic hernia, not the NRDS, without even looking at the at other symptoms. Okay, just this information is enough to diagnose you in the exam, right?
Yes.
Okay, so please remember the gestation age is very important to diagnose between the NRDS and the diaphragmatic hernia. Okay, if you somehow just missed all the symptoms and you're kind of very much confused in between these two options, then always look for the gestation age. Okay, but the symptoms for diaphragmatic hernia, it includes the respiratory distress, asymmetric aeration, because on the left side there will be stomach, no aeration will be present. The aeration will be only in the right side. Bubbles would be seen on the chest X-ray. Auscultation can show the bowel sounds. Okay, and you will get the scaphoid abdomen, you will get the respiratory distress, and all of these scenarios are because of an incomplete formation of phrenoesophageal or pleuroperitoneal membrane. Okay, and which part of stomach is herniated? It would be the fundus. Okay, so any doubts so far?
I have one confusion.
Yes.
Is congenital diaphragmatic hernia the same as paraesophageal hiatal hernia?
Yeah, paraesophageal, of course.
Okay, thank you.
Because of this paraesophageal hernia, the fundus will be in the thorax, so that your lungs can never be matured because of it, right?
Yeah.
And a space occupying area is present in the thorax, so lungs would be kind of lost. The tissue would be absent, right?
Yeah. That pulmonary hypoplasia is is seen in this case.
Okay, so this is a case of diaphragmatic hernia. Now the inguinal hernias, okay, which are of two types: the indirect inguinal hernia and the direct inguinal hernia. Indirect inguinal hernia, they take all the path, okay, which is made by the inguinal canal. Okay, they will pass first through the deep inguinal ring. Okay, and it happens because of a laxity in the inguinal ring only. Whenever the deep inguinal ring become very weak, okay, the abdominal contents can easily herniate into the inguinal canal through this inguinal ring. Okay, so first they need to pass through the deep inguinal ring. Okay, then they pass through the transversalis fascia, then they pass through the internal oblique, then they pass through the external oblique, and finally they will enter into the scrotum. As you can see, they are all passing through the inguinal ring, then the inguinal canal, then the external ring or the superficial ring, and finally they are entering into the scrotum. This is all the path which is taken by the indirect inguinal hernia. And if you know the location of the inferior epigastric arteries, then you can easily know that these hernias are always lateral to the inferior epigastric arteries. Very important. Okay, it happens because of a failure of processus vaginalis to close. Does anyone remember what is the function of this processus vaginalis?
Help is on testis.
Help. Help what?
Helps in the descent of testis.
Okay, and then what? What structure they form?
I don't remember that.
Tunica vaginalis.
Tunica, exactly, tunica vaginalis, which is the outermost covering of the testis. Okay, it is formed by the processus vaginalis. Okay, and these are also a part of your peritoneum. The processus vaginalis are also the peritoneum of the intestine, of the abdomen. Okay, so this processus vaginalis, they will always would take the same path as that of the scrotum, and they finally become the tunica vaginalis. Okay, and this area must be closed. But if you can imagine, if the processus vaginalis are persisted, then there must be a close connection between the uh, uh, between the layer of the testis and the abdominal contents, right? Because it was a peritoneum who was kind of herniating along with the testis, right? Is that okay?
Yes, yes.
Yes.
So now you get a close connection, because you know these the processus vaginalis are not closed, so there will be a close connection between the testis and the abdominal contents, right? And these contents can easily pass through this peritoneum, right, and can enter the testis. So they generally happen because of a failure of process of vaginitis to close. So it can be noticed within the infants only. Okay, if they can go unnoticed, then they will surely present in the afterhood, this adulthood. Okay, so they can be present into the infants as a bulge. Okay, if not, then they will be discovered in the adulthoods, and they can also extend into the scrotum. Okay, and they all contain and they contain the all three layers of the spermatic fascia. Okay, very important. Second ones are the direct inguinal hernia, and these are the most common types. They are 5 times more common than the indirect inguinal hernias. Okay, they happens because of a laxity in the anterior abdominal wall, because of a weakness in the anterior abdominal wall, and there is a triangle known as the Hasselbeck triangle.
Sorry to interrupt. Indirect hernias are more common or direct one? Because you have
Direct
written
one.
indirect
Oh,
hernias
sorry.
are yes.
Yeah, sorry. I'm sorry about that. Indirect, yeah, I'm really sorry about that.
No
Indirect
problem.
inguinal hernias are more common than the direct inguinal hernias. These are the most common type. Really sorry about that. 5 times more common than the direct ones. Okay, and yeah, so direct ones are basically from the Hasselbeck triangle. Okay, so what is a Hasselbeck triangle? In the medial wall of the Hasselbeck, this triangle is made up by the. Does anyone remember? The medial wall is made up by the
Midline.
the rectus abdominis.
Rectus abdominis, lateral wall
Yeah.
of rectus abdominis.
Lateral wall? No, medial wall, not the lateral wall. Medial wall is formed by the rectus abdominis. Okay.
Yes.
Lateral wall is formed by the inferior epigastric vessels. Okay, and the base is formed by the inguinal ligament. Okay, so annotate. So there would be your inferior epigastric vessels. Okay, there would be your rectus abdominis muscle. Okay, and vessels are kind of running like this. Vessels are kind of running like this. Okay, so they will form a triangle, and on the base you will have the inguinal ligament, right? So they will make a triangle like thing. Okay, and from this triangle, if there's a weakness present in the abdominal wall, it can lead to the herniation of the abdominal contents, and it is always medial to the inferior epigastric vessels. They're always medial to the inferior epigastric vessels, but lateral to the rectus abdominis. So the inferior mesenteric vessels are very much important in differentiating the indirect inguinal hernia from the direct inguinal hernias. Okay, and they only pass through the superficial inguinal ring, not through the deep inguinal ring. Okay. So because they're only passing through the superficial inguinal ring, which is in the aponeurosis of the external oblique, so they only contains the spermatic, external spermatic fascia, which is made up of external oblique. Okay. And they are because of a weakness in the transversalis fascia or the abdominal or the anterior abdominal wall. Okay, because of a weakness in the transversalis fascia, you can get the direct inguinal hernia. Okay. So yeah,
Yes.
that would be it. Any doubt?
No.
Okay, then you need to know about the. So yeah, how does a patient with the inguinal hernia present you? They will always present you with a bulge in the inguinal region first. Okay, and the bulge will be increased whenever you ask the patient to to do the Valsalva, right, where the patient is increasing the abdominal pressure. So in any scenario where the abdominal pressure is increased, like straining, coughing, right, or maybe the Valsalva time, right, in that case the bulge will be increased, and this bulge is most commonly painless unless the strangulation or the incarceration happen. Okay, whenever the strangulation happens, ischemia necrosis will happen, and in that case it will be very painful condition along with lots of inflammation, fever, pain will be there, right? But generally, most commonly, this condition is very much painless. Okay, it just presents you with a bulge, a painless bulge, which increase with the increase in abdominal pressure, like with the coughing, with the sneezing, with the straining, okay, with Valsalva. This is a classical presentation of the patient. Then comes the femoral hernia, which is kind of more common in the woman than in the man. Overall, the inguinal hernias are more common overall, both in male and female. But in females, uh, uh, more than males, females have this femoral hernia. Okay, and it is a protrusion below the inguinal ligament. See, the protrusion in the inguinal the direct and the indirect inguinal hernia is above the inguinal ligament. Okay, but in case of femoral hernia, this protrusion is below the inguinal ligament. Okay, very important. And as you can see in the diagram, this herniation is always medial to the vein. Okay, this herniation is medial to the vein. Very important. They will ask you this. Okay, the herniation is medial to the vein. Okay, so it protrudes below the inguinal ligament through the femoral canal, and it generally happens because of a weakness. Okay, it generally happens because of a weakness in a ring known as the femoral ring. So femoral hernia is because of a weakness in the femoral ring, and you guys know what structure passes through the femoral ring? We have discussed
Vein.
that previously.
Vein,
Not the
artery.
veins. No, lymphatics.
Okay.
Lymphatics pass through the femoral ring, right? And if the weakness in the femoral ring happen, it can lead to the femoral hernia. Okay, generally more commonly seen in the females. Okay, and these are the hernias which are most commonly incarcinated and strangulated. Which means whenever the hernia is incarcinated, it means it is trapped and it cannot be reduced now. Okay, and strangulations means the blood supply is kind of lost because of the compression, because as you can see, it is a very narrow passage, and all of the this content are passing through this narrow passage, so there will be like a strangulation happen. Okay, so this can lead to the necrosis and ischemia, and whenever the necrosis happens, this can lead to the pain. So a patient with the femoral hernia most commonly present you with the pelvic pain or the upper thigh or the groin pain. There will be a tender bulge, not a painless, but a very painful bulge just below the inguinal ligament. They will ask you this location. It is below the inguinal ligament, lateral to the pubic tubercle and medial to the vein, femoral vein. Okay. The patient can also present you with the nausea, vomiting, abdominal pain because of the obstruction. This part, as you can see, is obstructed. Whenever the food is passed through this part, it will be obstructed. That can cause the abdominal pain again, nausea, vomiting can happen, right? Blood flow will be impaired, and that can lead to the strangulations, of course, ischemia and necrosis. Okay, so this is about the femoral hernia. Just know the location. Females more common. Okay, know what structures are medial, which is the vein. What structures are medial, which is the lymphatics. Femoral ring is very important. Strangulations are more common. incarcerations are more common. Okay, these strangulation and the incarceration can also happen in the inguinal hernia, but more common in the femoral hernia, of course. So most of the time, you will always get a painful bulge in case of inguinal hernia, and a very painful, a painless bulge in the inguinal hernia, and a painful bulge in the femoral hernia. Okay, so we have discussed everything on this page now. Any doubt?
Can you please describe this descending of testes, which you have annotated?
See, the testis must be, so the formation of testis happens in the abdominal cavity. Is that okay?
Yes.
And from the abdominal cavity, the testis must be enter into the scrotal sac, right? So they need a passage, they need a path to do that, right? This path is provided by this inguinal canal. Okay. During the descent of the testis, what happens? First, they have to pass through the internal inguinal ring, okay, which connect this inguinal canal with the abdominal contents. So, so testes which are in the abdomen, they first enter into the inguinal ring. Okay, they will take first layer, which is a transversalis fascia. Okay, then they will move forward. They do not pierce the transversalis muscle or the transverse abdominis muscle. Okay, this muscle makes a kind of a bridge-like structure. Okay, over the canal. Okay, so no structure involved. Then they need to pierce second structure, which is the internal oblique muscle. They will take the layer of the internal oblique muscle while passing. Okay, then they need to again pierce the aponeurosis of the external oblique muscle, and from there they will get a third layer. Okay, so 3 layers of the inguinal canal are present. The layer name external spermatic fascia, internal spermatic fascia, and in between the cremasteric muscle and the fascia, right? The external part will be the external oblique, innermost will be the transversalis fascia, and the middle part will be the internal oblique. And that's how your scrotum will go through this path. They will take the layer of every muscle. They finally enter into the scrotum, and the inguinal ligament, this inguinal canal will contain all the 3 layers. Okay, to which the scrotum is pierced. Okay, now the vast difference, the blood vessels, the nerves which are supplying the testis, they all pass through this inguinal canal only. Okay, this is a use of the canal, the passes of the testis, and so now the talk about this, the processes vaginalis. These are the continuation of the peritoneum. You have the abdomen. You have the abdomen here, and you have the peritoneum of the abdomen, right? This peritoneum, right? This will herniate along with the scrotum normally, right? They will go all the way with the scrotum like that, along with the continuation with the abdomen contents. Now, finally, this area must be closed. Okay, and this layer will become the tunica vaginalis. Now, if this processes vaginalis are persisted, that means the connection with the abdomen, because here is the intestine, which is covered with the peritoneum. Now, this intestine can easily enter into this peritoneum, right? And it will be herniated. And that can cause the indirect inguinal hernia, right?
Right.
So that's about the indirect inguinal hernia. The direct one are medial to the inferior epigastric vessels. Okay, it is because of a weakness in the transversalis fascia, and as a result, the transversalis fascia will be bulge out from this external inguinal ring, like that. Okay, that's all about it. Now, any doubt?
No, it's okay.
So we are done with the anatomy part of the GI tract. Now let's discuss the physiology. Most of the things we have already discussed in the previous lectures. First is the gastrin released by the G cells, which are present in the antrum of the stomach. Okay, remember which gland secrete the gastrin? Gland name. We've discussed, I think, about an hour ago only.
Pancreas.
Gastric glands.
Yeah. Which gastric gland? 2 types of gastric glands are there. Oxyntic or pyloric?
Oxyntic.
not the oxyntic, but the
Pyloric
pyloric
one.
glands. Pyloric ones are in the antrum, right? We have discussed that. Pylorus is a part of the antrum, right? So the pyloric glands are present in the antrum, where they will secrete the gastrin by the G cells. Okay, and the function is to increase the HCl. Second thing is to cause the growth of the gastric mucosa. They will also cause the hyperplasia of the parietal cells. They will increase the gastric motility. Okay, they will be increased whenever you have alkalization of the stomach, where the pH is increased. Okay, and the secretion of gastrin will be decreased whenever the pH is decreased. Okay, very important. And whenever the vagus stimulations are there, which means the parasympathetic supply, you will always have an increased gastric secretion via gastric releasing peptides. Okay, whenever you take the proton pump inhibitors, okay, they will inhibit the HCl release from the parietal cells, and as a result, by the negative feedback, because you have an alkalization of the stomach, the gastrin secretion will be increased, right? So we'll get an increased secretion of the gastrin by the chronic PPI use. And now in this case, if you abruptly stop the proton pump inhibitors, what's gonna happen? All of the gastrin, will be stimulating the parietal cells, and as a result, you will get a very reflux increase in the acid release. Okay, you will get a very increase in the acid release, so you will get the GERD. Okay, you will get the heartburn. Okay, regurgitation would be there if you abruptly stop the PPIs. Very important. In case of atrophic gastritis, in chronic atrophic gastritis, what's gonna happen? You will have a high gastrin. Why? Because of loss of somatostatin cells first. As pylori will cause the destruction of the somatostatin cells, okay, the delta cells, and as a result, the gastrin will be increased, and that can cause the gastric ulcer. In case of Zollinger-Ellison syndrome, you will have a release of gastrin from the pancreas, right? And that can cause a distal duodenal cancers as well as the jejunal cancers. Is that okay about gastrin?
Yes.
Yes.
Gastrin are released from two places. One is from the antrum of the stomach. Second one, you told
Pancreas.
initially.
But a
Pancreas.
very minor in the pancreas, right?
Mhm.
Okay. Mostly from the major site is the antrum. Okay, the
All
major
right.
site is the antrum only. In case of ZD syndrome, okay, the release of gastrin is from the pancreas mainly. Okay,
And
now, then
secretin inhibit gastrin.
Secretin inhibits the gastrin. Okay,
And
then
it
comes
released from gastric mucosa.
Secretin,
Yes.
duodenum, S cells.
Okay, all right.
See, why you need the secretin? Because you need the bicarbonate from the pancreas, right? So whenever the acidic chyme enters your duodenum, you need the secretin to cause the increased release of bicarbonate, right? So this secretin must be present in the duodenum only. Okay. Okay. Now, second one is a somatostatin, which is released by the D cells. Okay. These D cells are present in the pancreas. They're present in the these are present in the pyloric glands also in the antrum part. Okay. So two locations, pancreas and the pyloric glands. Okay. They causes a decrease in the gastrin, decrease in the pancreatic fluid secretions, decrease in the gallbladder contraction, decrease in the insulin and glucagon. More insulin than glucagon, right? They will be increased by the acid. Whenever you have a high acid, the somatostatins will be released and they inhibit the acid formation. Whenever the vagus stimulation is there, that means you need the acid. That means you need to inhibit the somatostatins in order to do that. So by vagus stimulation, somatostatins are inhibited. By the acid secretion, by increasing the acid, the secretion will be increased. Octreotide is the analog. We have discussed every use of that this octreotide, the growth hormone, the acromegaly, right? And the carcinoid syndrome, variceal bleeding, and many other areas, you can use the somatostatin. Okay. Then comes the cholecystokinin, which is released by the eye cells. Okay, and it is present in the duodenum and the jejunum. The function is to cause the contraction of the gallbladder, which is the main function. And second most important function is the pancreatic enzyme secretion. Whenever we talk about the lipases, proteases, okay, from the pancreas, they are only released by the cholecystokinin. So the function of cholecystokinin is to release the pancreatic proteins and the enzymes, I must say. Second is the gallbladder emptying by causing the gallbladder contraction. They will decrease the gastric emptying. Okay, they will just they are not a gastrin inhibitor or a gastric acid inhibitor. Okay, they do not inhibit the HCl production. They just decrease the emptying for cystokinase, and they cause the relaxation of the sphincter of Oddi, so that a bile will be released in the duodenum. They're always increased by the fatty acids and the amino acids because that's where you require the biles. Okay, and yeah, acts on neural muscarinic pathways to cause the pancreatic secretions. Then comes the secretin, which is released by the S cells in the duodenum. That causes the increase in the pancreatic bicarbonate. So whenever we talk about the enzymatic secretions, we will always discuss the cholecystokinin. Whenever we discuss about the secretin, that means we're talking about the bicarbonate secretion only, not the enzymatic secretions. They will decrease the gastric acid secretion, very important. Okay, called CCK hormone for the decrease in gastric emptying, secretin for the decrease in gastric acid production. Okay, and they will also increase the bile secretion. Similar to the CCK hormone, they will always increase by the fatty acids. Okay, and they will increase the bicarbonate so that the the gastric acid in the duodenum could be neutralized. Okay, so that the pancreatic enzymes can function. So can anyone tell me why we need the acid in the stomach?
Protection
To kill
from
the
microorganisms.
bacteria present in our food, maybe.
Is that
For
the major thing
activation of
why we need the
pancreatic
acid?
enzymes.
Yeah, the pancreatic. No, not the pancreatic enzymes. We need gastric acid for a specific reason, for a most important thing.
For
It's not the
For
bacteria.
intrinsic
For-
factor activation.
Protein.
For
Jason.
Pepsinogen
enzyme
activation.
for enzyme activation. Protease is pepsinogen. You know, pepsinogen need to convert into a pepsin by the HCl, right? So can anyone tell me why you need the pepsin when you already have the pancreatic enzymes, proteases?
Pepsin is the largest exopeptide. So it can cleave large molecule into small ones, and so that further pancreas enzyme and can act.
And what happens if I lost the pepsinogen? Anyone? If I lost the pepsinogen, what's going to happen to my protein metabolism?
Reduced absorption.
Reduced,
Why?
because
I'm still-
pepsinogen will not be converted into pepsin.
So I still have the pancreatic enzymes. What's the problem then?
Probably pancreatic enzymes can act on smaller peptides.
Exactly. Pancreatic peptides, the pancreatic proteases can act only on the smaller peptides, not on the large peptides. Okay. And whenever you ingest the proteins, you always ingest them in a very large complex, these polypeptides. Okay. So they need to be converted into simplistic molecules, a very shorter segments, so that these the pancreatic enzymes can act on them. So in a scenario where you lose the pepsinogen, you will use this protein absorption completely. Okay, because these pancreatic enzymes cannot act on the large polypeptides. Is that okay?
Yeah, okay.
Okay, so we were talking about the secretin for the bicarbonate. Okay, and for the pancreatic enzymes to function, they need the bicarbonate media. They need the alkaline media, right? Not the acidic media. Then comes the glucose-dependent insulin peptide, which are the GIPs. You guys remember their function? They will cause a decreased glucagon. They will cause an increase in insulin. They will cause a decrease in the gastric, the delayed emptying of the stomach, right? Very important. And they will also decrease the gastric H plus secretion. So whenever you ingest the glucose, okay, they will be activated. Okay, and one of the important thing you need to understand that whenever you take an IV glucose, okay, you won't have that much insulin release. Okay, as much you get when you take the oral glucose. Okay, if you take the oral glucose, then you have more this insulin release than the IV glucose. Why? Because in case of oral glucose, you will have the GIPs will be
GLP.
also released. right? And these GIPs will further stimulate the insulin release. But if you take the IV route, okay, then glucose won't enter the stomach, it won't enter the intestine, okay? And if they do not reach the intestine, then these GIPs and the GLPs, they won't be released, and as a result, you won't get a increased insulin secretion. So if step 1 asks you, okay, why on the oral why on the oral glucose you're having more insulin than the IV glucose? It is because of the GLPs and GIPs. Okay, very important. Then the motilin receptors, okay, these are present
GLP and GLP are same, right?
kind of different see, their function is kind of same, okay, but structures are different.
All right.
And then comes the motilin receptors. These are the receptors on your GI tract. Okay, they will cause the increase in the peristalsis, increase in the motility. And very important to recognize that erythromycin or other macrolides, antibiotics, they will stimulate the motilin receptors. And that's why I will take the erythromycin for the treatment of diabetic gastroparesis.
Yes.
Okay, please note that fact. We will use the erythromycin for the treatment of diabetic gastroparesis because they stimulate the motilin receptors.
And why
Then
we cannot use dopamine 2 agonists? Because they
we can use that.
We can use that, but it can cause extrapyramidal symptoms. So
Yeah,
erythromycin is
of
preferred.
course. We need to use them with the other antihistaminic also, right?
Yes.
Exactly. So now comes the vasoactive intestinal polypeptides. Okay. For the vasoactive intestinal polypeptides, you first need to see that they're released by the parasympathetic nerves, not the sympathetic nerves. Very important to note. They will be released by the vagus stimulations only. Okay. So their function is to relax the intestinal smooth muscles and the sphincters. They will cause a nitric oxide release, and by the nitric oxide release, they will cause a relaxation of the smooth muscles. Second thing, they will cause the increase in the intestinal water and electrolyte secretion. Very important, they will cause an increase in the intestinal water and the electrolyte secretion. And second thing, they will cause the relaxation of the smooth muscles and the sphincter. So in a scenario where you have a very high VIP release, or I can say the VIPoma, okay, you will have a characteristic watery diarrhea, which is a secretory diarrhea. And the characteristic feature of a secretory diarrhea is that you will get a diarrhea even when you are not eating anything. Even when you are fasting, you will get a diarrhea. And the step 1 will generally tell you that a patient, often wake up from the sleep for a defecation, for a diarrhea. That means, she's having a diarrhea even at the empty stomach. And it is a very characteristic feature of the secretory type of diarrhea, which is seen in the VIPoma. Second thing, you will have a hyperkalemia because of increased secretions. Okay, you will have a achlorhydria because of a loss of this gastric acid secretions also. Okay, and yeah, this is known as a WBHA syndrome: watery diarrhea, hypokalemia, and achlorhydria. Other things will be the hyperglycemia also. You will get hypercalcemia. You will get. Okay, very important. And yeah, that would be all about the VIPoma. Now, then is the nitric oxide, which is the relaxing of the smooth muscles. It will cause the relaxation in the lower sphincter, lower esophageal sphincter. So in a scenario where you have a destruction of the parasympathetic neurons, which are releasing the nitric oxide, okay, so loss of nitric oxide secretion can lead to an increase in lower esophageal sphincter tone, and that can lead to the achalasia. And does anyone remember the treatment for the achalasia? We have discussed that in the microbiology. Botox, yes, because it causes the relaxation, because they inhibit the ACH release, and without ACH you won't have any contraction, right? Very important. Then finally, the ghrelin, we have discussed that already. Whenever you are empty stomach, the ghrelin will be increased. And on which center of the brain they will act?
Hunger center.
Which one?
Hunger center.
Yeah, where the nucleus, the lateral or the medial hypothalamic nucleus? Yeah, exactly, the lateral nucleus. You can remember them by the mnemonic that lateral will make the damage to the lateral nucleus will make you lean, because the ghrelin will be acting on the lateral nucleus, causing the hunger. Okay, if the lateral nucleus is damaged, ghrelin cannot act on the lateral nucleus, and that will make you lean or a weight loss, right? And they will be released by the stomach. Okay, they will be increased in the fasting state and decreased by the food. They will be increased in the parietal villi syndrome, and they will decrease after the gastric bypass surgery, because in the case of gastric bypass surgeries, stomach cannot release the ghrelin to the circulation, right? That's all about the GI hormones. Any doubt on that?
Wait, so does that mean that after gastric bypass, when you will not feel hunger if you cut out the ghrelin area?
It's not that much simple. See, there is a hunger for the hunger of the ghrelin. You have the neuropeptide Y, right? And other hormones are also there, right? This is a major one from the stomach. In case if you're doing a gastric bypass surgery, yes, of course, your hunger will be reduced, but not inhibited completely, right?
Okay.
It will be reduced because you're bypassing the stomach. And if you're bypassing the stomach, then how will stomach, secrete this ghrelin into circulation, right? So ghrelin will be reduced, hunger would be decreased, but not completely inhibited, because other hormones are also there. Leptin's level will be decreased, right?
Okay.
And
Okay.
and on these centers, on the lateral and the middle nucleus, okay, even though the ghrelin is stimulating the lateral nucleus, this leptin will inhibit the lateral nucleus, right? And similarly, for the middle nucleus, the ghrelin will inhibit the middle nucleus and leptin will activate the middle nucleus. So it is kind of a balanced thing. Both the hormones are acting at both areas. In one area they will be activating it, in one area they will be inhibiting it, right? So there's a kind of a balance always, right? Whenever you lose the ghrelin, because of the weight loss, you will also lose the leptin, right? So balance would be restored, kind of. Okay. So, and other peptides are also there, just like the neuropeptide Y is also there for the hunger. So hunger kind of reduced, but not inhibited completely.
Okay. So you, without the ghrelin, you just have one less hunger signal, but it's not gone completely.
Yeah, exactly.
Okay, perfect. Thank you.
Okay. Any more doubt? No?
No.
Okay, I think then we should wind up here for now. Is that okay for everyone?
All right.
Yes, sir. That's fine. I had one question, kind of general question.
Yeah, do ask.
So does diabetes cause diarrhea and
Yeah.
sometimes it also causes constipation?
Yes.
Okay, in what situation would it cause diarrhea versus
See, if the parasympathetic neurons are damaged,
uh-huh.
then you will get the constipation, which is known as a diabetic gastroparesis.
Okay.
Right? In case you're damaging the sympathetic fibers, then parasympathetic fibers will be there, and that can cause a diabetic diarrhea. So it depends. Sometimes patients can get the diarrhea, some patients can get the diarrhea, some patients can get the constipation, and totally depends. The glycosylation is happening at what neurons. Damaging is happening at what neurons. Okay.
So it's
basically,
random.
neuropathy is responsible for that.
Yeah, exactly. Autonomic neuropathy.
Okay.
It could be
Okay, so
parasympathetic, it could be sympathetic.
Okay. Okay, that works. Thank you.
Thank you.
Sorry, my other question was there's no like time situation, right? Like early or late or anything. It's
No.
completely random.
Yeah, of course.
Okay.
Generally,
thank
it happens after 5 years of the diabetes, when the
Mhm.
glucose overload has become like too much, right? After
Mhm.
5 years, generally, it will happen. Not before 5 years. You cannot see any complication of diabetes before 5 years, I think.
Okay. Perfect. Thank you.
Okay. Any more doubt regarding previous pages or this page?
No, thank you.
No, thank you.
Okay. Thank you so much, everyone.
Thank you so
We will
much.
take today's off from here.
Thank you.